Good morning, Dr. Jailal, sir.
Good morning. Good morning.
We'll be starting in a couple of minutes, sir. Thank you. Thank you for joining.
Okay. Thank you.
Good morning, Dr. Srinivasan.
Good morning, sir. How are you, sir?
Bas, absolutely fine. Thank you for joining again.
How is
on
Modi,
Monday
sir?
morning.
How is Pankaj Modi, sir?
He'll be joining a couple of minutes. He should be joining. He is fine, sir.
Jailal, sir, namaskaram.
Namaskaram. How are you?
Fine, sir. How are you, sir?
Fine.
Last time I passed through your nursing home but couldn't meet you. The
Why?
one false இதுக்கு வந்தல்ல சார்.
Right.
அது மார்னிங் வந்துட்டு நைட் ரிட்டர்ன்.
Okay.
Good morning, Dr. Ritesh, sir. Dr. Ritesh Agrawal, sir.
Hi, sir.
Thank you for joining on this case of thyroid, please. Thanks a
My
lot.
pleasure, sir.
We should be joined by Dr. Urvi Parekh also.
Yes, sir.
She is a consultant endocrinologist, senior endocrinologist in Ahmedabad. She should be joining also in a couple of minutes, and Dr. Pankaj Modi, sir.
Okay, sir.
Florina, I think you have stopped sharing the slide, or it's off my laptop, I don't know.
Hello?
Are you sharing the slides? Screen sharing has started?
Morning, Modi, sir.
Good morning,
sir. How are you? Sorry to be late.
No, sir.
Guest, so I had to rush. Apurva?
Yes, sir. You are almost ready. Urvi ma'am no phone karo. Join karo chu.
Thank you, Srinivasan, for joining.
Thank you,
Yes.
sir. Thank you
Dr.
for
Jailal,
inviting
Dr.
me.
Srinivasan sir and Dr. Ritesh Agrawal are there with us.
Okay.
I think છોકરાઓને કંઈક screen sharing માં problem they must share the
Okay, no
screen.
issue, no issue.
Give us a couple of minutes.
Okay, sir.
Sir, how are you? We met after a long time, even on online.
Yes, sir.
Srinivasan, sir.
Yes, sir. Yes, sir. Yes, sir.
That my resident has passed out and now she is at Pune.
Yes, sir. Nupur.
Nupur, she is at Pune doing aesthetic, something like that.
Something. Very sincere student, I heard.
Yeah. The best part was her father was also my resident.
Oh, very good, sir. He's also a surgeon, sir.
Second generation, actually.
He's also a surgeon.
Yes, he was my resident in 1990.
Oh, 90. Oh.
He's practicing at Nadia, around 60 kilometers from Ahmedabad.
Oh, right, sir. Give it to me.
Abhijit, problem solved થયો ભાઈ?
Good morning, Jailal sir. Very good morning.
Morning.
Thank you for joining, sir.
Thank you, sir. It is always because you are there. It will be a pleasure.
Thank you, sir. We meet a lot of time for that. That's good. Yes, I think yes. Now we are on the way, right?
Hello.
Sir, shall we start?
Yes, please, sir.
Definitely. Acha, okay. So your video was not okay. Great. Let us start.
Urvi
Please
madam has
introduce
also
everybody
joined.
again.
Sorry, sir.
You have introduced everybody.
Oh no, sir. Oh, okay.
Let us do it because the resident may not know exactly.
Okay,
Yes.
so this is another PG masterclass, a case on thyrotoxicosis. We previously had a multinodular goiter a couple of weeks ago. We have with us a panel of teachers and experts in this group. Dr. Jailal sir, who is a professor and HOD at Kanyakumari Medical College, and Dr. Srinivasan, who is HOD and professor at CMC Coimbatore. We are joined by Dr. Jayesh Parikh, who is a professor of surgery at BJ Medical College. And sorry, I forgot, Dr. Ritesh Agrawal is there from Leelavati Hospital, ex-endocrine surgeon, and he has agreed to join and give his inputs. Thank you, sir. We have Dr. Urivian, who is a consultant endocrinologist at Ahmedabad. She has joined. She has some issues with the voice, but that we'll sort it out later on. As per all the cases, this masterclass, the student will be presenting online the history part, followed by a summary of history. Then we can ask questions, followed by the examination and investigation part. Again, question answers, and followed by any investigations and any treatment plan and all those things. The experts and the teacher are allowed to stop at any given moment to stop the candidate if they find that there is some grievous mistake on the part of the resident. So you are allowed to break the schedule at any given moment, sir. Okay, sir, shall we start?
Yes, let us start. Let us roll it.
Dr.
Okay.
Pankaj Modi, sir, and I'll be acting as a moderator. We'll be helping out the student if at all if there is any issues. Florina, better start.
Yes, sir. Good morning, sir.
Good morning. All the best.
Good morning. Welcome.
My case on the case presentation on the thyroid swelling. I am Dr. Florina Malek, third year surgical resident under Dr. Apurva ji sir and Pankaj Modi sir, and Vinit Chauhan sir and Malek Mehta sir. A 36-year-old Hindu female patient residing at Ahmedabad, housemaker by profession, belonging to lower socioeconomic class, presented in OPD with excessive sweating, intolerance to heat and tremor 2 years back, swelling in front of neck since 2 years, weight loss of 10 kg over 2 years, and protrusion of eyes since 2 years. ODP, patient was relatively asymptomatic before 2 years. Then she developed excessive sweating, intolerance to heat, tremor, and insomnia 2 years ago. Then relatives noticed swelling in front of lower neck 2 years ago, which was insidious in onset, smaller in size, and then gradually increased to present size, which was not associated with pain or fever. Patient have a history of weight loss of 10 kg over 2 years in spite of good appetite. Patient have also complained of protruding eyes since 2 years. Not associated with palpitation or dyspnea on exertion. Not associated with the pressure symptom. Not associated with bilateral lower limb edema. No sudden change in the voice. No sudden change in the size of the swelling or hoarseness of voice. No any other swelling in the neck. Patient is consulted to a physician. Some blood reports were done and started on medication. Tablet form 4 times a day 2 years ago. Then dose were increased in subsequent follow-up. Then patient have improved in some of the symptoms. Past history. Patient have no history of diabetes mellitus, hypertension, or tuberculosis. No any history of past radiation exposure. Patient is operated case of tubal ligation 6 years back. Patient have no other family member have a similar complaint. Personal history. Patient is vegetarian by diet. Bowel and bladder were regular. Sleep is adequate, and appetite is increased. Last menstruating period, 26th of the March 2024, regular menstrual cycle. Obstetric history. Patient have a 2 live child, 2 gravida, and 2 para. No any abortion, and patient have a full-term normal delivery. Summary of my history. 36-year-old female patient from Ahmedabad come to OPD with complaint of excessive sweating, intolerance to heat, tremor, and insomnia 2 years ago, with swelling in front of lower neck since 2 years, which is gradually increase in size associated with weight loss of 10 kg over 2 years, and a protrusion of eye, which is noticed simultaneously. Patient on medication and somewhat symptoms were improved without any pressure symptom or no any significant past or family history.
Yeah, Florina, I think you have presented well. But my only question I wanted to ask, you are putting everything for 2 years. Swelling started 2 years, symptoms started 2 years, weight loss for 2 years. So you mean to say that everything have simultaneously happened. But equally you said patient is on treatment since 2 years.
Yes, sir.
I mean, we couldn't understand a patient who's under treatment for thyroid problem, not responding to anything, but continuously having all the disease and all the problems. That is what you are presenting?
No, sir. Patient on medication. A patient have a improvement in the symptom like tremor and
You
sweating.
are not summarized like anything. It is a continuous progressive disease. The nodule is progressing, weight loss is progressing, and all the intolerance to heat, excessive sweating, all this is heat and tremor and insomnia 2 years ago, that is starting.
Sir, here she has written that patient on medication with improvement in some symptoms.
Yeah, sheet.
In the summary as well as in the ODP, she has written that all the symptoms have not improved. But Florina, did she consult the physician immediately after her symptoms, or it was later? Because everything is since 2 years. I agree with Jalal, sir.
Yes, sir. Patient is consultant to physician after 1 month of onset of symptoms, sir.
She noticed everything. This
To say the progression, which started first, then which says when the patient has noticed the swelling. So by thing, when you say that symptoms and the swelling the same time, that means the swelling is there much earlier. The swelling to be obviously seen by someone else, it takes some time, but the symptoms will be seen immediately. So now, according to your presentation, the symptoms and the sign of the swelling was at the same time. That means indicate the swelling was there earlier. So when nothing wrong in that, but when it is a routine for the postgraduate, everything put at the same time 2 years. But you need to spend some more time and ask which was the first symptom and how it has progressed and what was the swelling progress. So little more details of that you need to give. That's fine.
Florina, how many chief complaints are there?
Patient have a chief complaint of excessive sweating and intolerance to heat and tremor 2 years ago. Swelling in front of lower neck.
So one minute, chief complaint is only one, which compels the patient to attend and on which you can keep the differential diagnosis. So there should not, all others are the associated complaint. So make chief complaint only one, which compel patient, because it is for the 2 years when patient present to you, what is her complaint?
Patient presented to me for swelling in front of neck since 2 years.
Yeah.
But normally chief complaint is what made the patient to come to you.
Yeah.
Swelling is there for 2 years, but why he is coming to you after 2 years?
After two, sir, patient is referred from physician for the large swelling in the neck, sir.
Florina, another question. Can you able to keep the differential diagnosis of ill tolerance to heat? Or it is better to keep the differential diagnosis of swelling in the front part of the neck? Which one is easier for you?
Swelling in front of the neck.
So make it as a chief, because patient had all the complaint for the 2 years, and as sir has told, yes, she has come after 2 years. So what compel her to, and always make chief complaint only single complaint. Chief is always one. All are associated or additional.
Especially in the summer holidays, what you are talking about, excessive sweating and intolerance, is not a important thing because it can be a seasonal also. Similarly, do you think a tremor will be a significant feature in a thyroid patient? What do you mean by tremor?
Involuntary shaking movement of the limbs.
So can you, is it a fine tremor or a cold tremor you get in a thyroid?
A fine tremor.
Fine tremor. Is it a fine tremor is always obviously seen. You need to keep something in the stretch hand, paper, put up paper, and to see, because that is the way. The fine tremor is just what is, why you get the thyroid tremor? Is it a physiological tremor or pathological tremor?
It is a pathological tremor.
No, it is not pathological. It is always a physiological, exaggerated physiological. Normally, like anxiety, anything, you are sympathetic overactivity, which is only causing the tremor, which is always a fine tremor. So many times, unless you elicit, I mean, the patient may not have that complaint. That will not be a very significant complaint for the patient. So, because excessive sweating, intolerance, and tremors, there are so many other reasons. When the obvious tremor is there, then there are so many other reasons should be there. So that do not fit into the thyroid as a first. And if you have said swelling in front of the neck is the major cause, then it would have been easier for you to go ahead on that.
Can you, hello?
Yes, ma'am.
Can you differentiate clinically that person coming with a hyperthyroid 334 TSH, and can you differentiate whether it is a thyrotoxicosis or a thyroiditis clinically?
Clinically, in patient with thyroiditis, it was associated with the pain, with enlarged swelling in front of neck, with pain, and associated with fever.
And what is the
one specific sign that is present in this case and will not be present in thyroiditis? One specific sign?
Ma'am, protrusion of eyes.
Yes, exophthalmos never present in thyroiditis. Okay, and is there any increase in the swelling at the time of presentation, as sir was asking, that what was the reason for presentation after 2 years? So there may be increase in the size of the swelling.
Madam, basically the thing is the patient came to us only for swelling.
Okay.
She has been treated by a physician and she was already on medication. some of her symptoms did improve, but the swelling never improved. So she consulted us that what can be done, and she was referred that way.
Okay.
It should be presented in that way. That is the main thing which is symptom.
Right, sir. We wanted this discussion because how the examiner will take, we don't know. You are absolutely right, sir. Florina, this is for learning purpose. That you have to present it the way the examiner asks. Right? Correct.
You
And
said
in
it is
origin,
thyroiditis
duration,
painful. Do you think
progress.
all thyroiditis are painful? What is the painful thyroiditis?
There is a discomfort in the neck.
No, sir is asking what type of thyroiditis are painful.
Hashimoto thyroiditis produce the discomfort in the neck, and the subacute
pain. Discomfort is different. It can be to anything. It can be a pressure can produce a discomfort. Lot of things can produce a discomfort. But pain is only specifically when it is due to subacute granulomatous thyroiditis or a decurrent thyroiditis is a painful condition. All other thyroiditis is relatively, it is a painless condition. So pain cannot be an attributing factor. You cannot differentiate that.
Srinivasan, sir?
No, sir, she is doing fine, but only thing, the swelling in front of the neck should have come first, followed by your symptoms. Okay. Otherwise, you are presenting well, you are answering well. All questions has been asked. Very good.
Go ahead, ma.
The protrusion of the eyes also, the patient gave the complaint or somebody told?
Sir, patient herself said that protrusion of eyes.
Weight loss also is at 10 kg. Did you measure? Did the patient tell you, or they will say loss of weight, isn't it? In spite of good appetite. 10 kg you measure put, that's what we are asking. As the Jailal said, excessive sweating and intolerance to heat in this summer, that cannot be the presenting complaint. Okay. The chief complaint, you put it as swelling in front of the neck. Nothing wrong, ma. Carry on. We had just some corrections. So,
May I ask something?
please, sir.
Yeah, Florina, it was a very good presentation. Thank you so much. So you have written in your history on the next slide. Can you go to the next slide, please? Just next slide, yeah. So you have written that intolerance to tremor and insomnia. What are the other psychiatric symptoms which you should have asked and are not mentioned in this history?
Patient have anxiety, excessive sweating, and
I am asking about psychiatric symptoms. You have written insomnia. What else?
Anxiety.
And?
Psychosis.
Any mood swings?
Yes, mood swings and psychosis.
See, anxiety is a very common feature in hyperthyroidism. So you should have mentioned it properly. And are you sure that there are no palpitations? Because you have mentioned there are no palpitations. Are you sure about it? That there were no palpitations from the beginning?
Yes, sir. I have asked the patient. Patient do not have a palpitation.
Okay. Come to the next page, please. Next slide. See, you have written pressure symptoms. A student should not mention pressure symptoms. They should elaborate what are the pressure symptoms you have asked to the patient and what whether they were present or not. So what pressure symptoms you had asked from the patient?
Patient have a dyspnea of voice, dyspnea on exertion, sorry, a dyspnea or dysphagia or
just a minute. Dyspnea and dysphagia technical terms. You have to elaborate in the patient's language and history.
Difficulty in breathing.
Yeah.
And difficulty in swallowing of the food.
How do you expect thyroid to produce difficulty in swallowing?
By constricting the esophagus.
Oh, just what is the relationship of esophagus to thyroid?
Inferior constrictor, cricopharyngeal part of the inferior constrictor attached to cricoid, and
I am not asking the way it moves. Ma. What is the relationship? Is it posterior to thyroid? Posterior to thyroid is trachea. If at all you say, even trachea is very less.
Covered
This is still posterior to trachea. So do you think thyroid will compress on the trachea and then compress on the esophagus? And which part of the deglutition you are expecting dysphagia? What are the phases of deglutition?
Deglutition, first the central component, then the gastric.
No. The deglutition, once it reaches the gastric, it is a digestion part. Deglutition do not come to the, so oral phase, pharyngeal phase, and esophageal phase. Normally, thyroid, posterior to thyroid is not esophagus or pharynx. It is only, means esophagus or the pharynx. Yes, larynx and trachea only posterior. But yes, you can explain by saying sometimes, especially in Hashimoto's, it goes laterally. It is a posterior-lateral compression, not anterior-posterior compression. From lateral to medial, it posterior-lateral, the lobes can put, and patient can have a symptoms of esophageal or deglutition problem. But normally, it will not produce. It cannot produce a trachea and then produce on that.
Yes.
What are the other pressure symptoms?
Dyspnea and change in voice, sir.
Change in voice. As a pressure symptoms, how?
Large thyroid compresses the recurrent.
Why it produces change in voice?
Large thyroid compresses over the recurrent laryngeal nodes.
No, let the recurrent laryngeal be compressed, but why it produces the hoarseness of voice? What is the mechanism? It produces the hoarseness of voice.
Recurrent laryngeal now supply the motor muscles of the vocal cord.
Vocal cord, all the muscles.
Except cricothyroid.
What is the commonest cause? Somebody with the thyroid swelling comes to you with the hoarseness of voice. What do you think is a common cause? Is it hyperthyroidism or hypothyroidism?
Hypothyroidism. Hypothyroidism.
Hypothyroidism is always the common to produce the hoarseness because of the laryngeal edema, vocal cord edema it is producing.
Okay, Florina, come to the next slide, please.
Yes.
More precious symptoms you would like to elaborate just for the benefit of students?
You said
Detailed by
only three
Jagan, sir.
component. Anything else? Florina? Oh, yeah.
Do you know Florina or sir will answer?
Sorry, sir, I didn't hear, sir.
What are the other pressure symptoms? Services.
Dyspnea.
No, you have said already dyspnea, dysphagia, difficulty in breathing, difficulty in swallowing, and voice change. Other than that, can it produce a syncopal attack? Can it produce the flushing of the mouth, face?
No, sir. Yes, sir, it can.
And also can produce a very rare, but Horner's syndrome also you should include because it can include the sympathetic chain and produce.
Yes.
You remember two tubes, ma? Trachea and esophagus. Remember two vessels. Okay. Sometimes you can compress the carotid and the jugular vein. So you are flushing your face. Remember two nerves. One is, as you said, a recurrent laryngeal nerve, and as I said, if it is very pathologically, it is aggressive tumor, can go and compress the hormone. These are the pressure symptoms you should ask for.
Yes.
I think Sarah has told everything. I'm repeating it. So.
Next
Good,
slide,
sir.
please.
Thank you. Next. Ritesh bhai,
Next
anything
slide.
from your side?
Yeah, that's why. Next slide.
Fine.
Yeah, Florina, you had asked about a diet. Diet is very much important in hyperthyroidism patients. How?
In hyperthyroidism patient, any drug, any diet which is a goitrogenic, which causes the enlargement of gland.
I am asking about hyperthyroidism, not about the size of thyroid or goiter. I am asking about hyperthyroidism. What kind of diet is important in hyperthyroidism? What thing is important? She is having a veg diet, that's okay. Granted. But what else? Would you like to ask about in the dietary habits?
Iodine, excessive of seafood.
See, she's not taking seafood. She's not taking any non-veg item because she's a vegetarian. What else you would like to ask in her diet?
Cabbage.
Apart from that, do you know about the implication of salt? Which kind of salt is she using?
Iodinated or rose.
Yeah, because iodinated salt can aggravate the hyperthyroidism. So you should have taken this history very meticulously.
Yes.
Okay.
That is
so,
more important than your diet. Do you think a cabbage, what the way we eat in India, will cause hypothyroid? How do you eat cabbage? We always eat by cooking or boiling. Never
Yes.
use as a salad.
Yes, sir.
So when you cook, the thiocyanate in the cabbage or flavonoid in the soybeans, all will be go away. That will not cause an Indian setup.
Yes,
Can a seafood produce hypothyroidism?
Yes, sir. In seafood, there is a low iodine in seafood.
Seafood always has a high iodine.
How are you doing?
Sorry.
Seafood can cause, even the people who take lot of small fish can have hypothyroidism because of the mechanism of absorption of iodine, competitive inhibition of the iodine. In this, when the sodium importer is acting, it competitively take the calcium instead of iodine. So even though they take, because it is absorption will not be there, which is competitively be inhibited by the calcium, the people can develop. That is why in the even the sea belt, we get a lot of cases of hypothyroidism. So that is your personal history should be a little more focused, not like an undergraduate presenting vegetarian diet. Sir has very particularly asked what is particular to this disease when you are expecting thyroid, and what type of things you are asking, what kind of craft. You are very only one word you have said, there is no other family members is suffering.
Yes, sir.
And appetite is increased, you have said. How do you come to a conclusion appetite is increased?
Sir, patient have a patient says that patient increase the food intake.
Last 2 years is can you quantify? Can I say like that? Somebody having an increased appetite for 2 years. Have you, on the day of your examination, have you asked what type of the food she has having? How much morning diet she had taken?
So how does she say that she has increased appetite? Has it increased, the number of chapatis has increased, or consumption of rice? Have you asked something like this?
Sir, frequency of consumption will increase.
That is what now all the doctors are advising. No, we increase the frequency and reduce the quantity at a time.
Quantity.
No, what I understand is you are only trying to put in your theoretical knowledge into the case presentation. But what we expect in the examination is the student should ask what exactly the patient is feeling, what exactly the patient problem, and try to bring it out. Don't make a big judgment in saying the personal history appetite is increased. That is a very it's very difficult to make, because we are not sure that what kind of habit they take, what the type of thing they are taking.
For this case, you is the case with you. You go back and ask Florin that how was he taking 2 years ago? How is he taking now? And for the past 2 years, how is it? See, the quantity should be increased. So after 1 hour, again he'll eat the same quantity, and he'll have severe diarrhea. The patient has diarrhea.
Even a diabetes, you should rule out then. They
The
can have.
the patient
You should
had
rule out
diarrhea.
diarrhea, early satiety.
Is he having diarrhea? Taking
Between
food,
appetite and
going.
early satiety. Is it is just because he's taking the food, but it is entering again, she is getting hot. So little more specific details if you can put, that will be good. Similarly, in your next question, you have put as a, see, your patient has 2 years, all the symptoms, tremor is there. There is a high end of the hyperthyroidism, but menstrual cycle is normal. you are expecting this to happen?
Sir, patient mainly have a amenorrhea in such patient with hyperthyroidism.
Why? Why there is amenorrhea?
More common than amenorrhea. What kind of menstrual irregularities you see in hyperthyroidism? More common?
Polymenorrhea.
No. It is oligomenorrhea. Amenorrhea means the patient has to.
Will not be
sorry.
there.
Yeah.
Now, what is the mechanism? What do you think it is happening? Thyroid, and what is the relationship with the menstrual cycle?
I'll give you a clue. There is something between thyroid hormone and FSH.
Yes.
Can you catch it?
Sharing the same alpha subunit.
Yeah, all
Alpha
coming from
subunit.
the
Yeah,
same
that's
place.
good. That's good. Very good. Very
Directly
good.
proportionate to that. Okay.
So,
And
Florina,
in the obstetric history, what we want was one is the LCB. So then what you are saying, it's a full-time normal delivery. That is does not gives the important, because this during this 2 years period, that is a very significant period for us.
Yes, sir.
So is it an LCB was happening at that time, or it is much earlier? What is the last childbirth?
The delivery, when was the last live birth? How many years ago, sir is asking?
Sir, before 5 years, sir.
So that history actually does not have anything to do with this thyroid status, right? Okay.
Florina, history of any thyroid disorder during pregnancy is also important.
Yes, sir. Yes, ma'am.
Yeah. And what is another cause of increased appetite with loss of weight?
It also seen in the type 1 diabetes mellitus, anorexia nervosa.
Only type 1?
Type 2 will not cause, huh?
In diabetes.
In diabetes, yes. And what is the cause of absence of palpitation in this patient?
Pathology of palpitation, madam is asking. Rather, pathophysiology.
Due to increased thyroid hormone, there is a increased metabolic rate, and it is associated with the increased tachycardia and causes the palpitation. Palpitation.
Why is absent in this case? You have mentioned no? There is no palpitation.
Which hormone is produced more, ma? T3 or T4?
Palpitation more produced by sir.
Florina, did you ask the patient's palpitations was present before and after treatment was absent? Then you have to mention it.
So important is maybe patient is on this propranolol and patient is not having palpitation. That is possible. Yeah, and patient may be having irregular treatment, and when he presented to you, the treatment. Yes.
Basically, the patient was taking only carbimazole. The physician never advised propranolol.
Okay.
Okay.
So, and probably that was one of the reasons why her symptoms did not relieve completely, and she persistently had some of the complaints.
Right. But the absence of palpitation is then surprising. Even if the patient is having tremors.
Jailal sir is saying the same thing.
Yeah, tremor is. But bowel habits and menstrual cycles are normal.
No, T4, T3, which is produced more, ma, from the gland?
T4, sir.
T4. Then why, what happens is T4, what happens to the T4?
T4 then converted to T3 in peripheral tissue.
What are the peripheral tissue where it gets converted?
Is converted into GI tract, in heart, in
the muscles also, skeletal muscles also.
Yes.
That is why sir has said that that should be also targeted. Not only the hormone production of T3, which is central, that the T4 to T3 also should be targeted. Okay. You put sleep adequate. Are you justified in it? Please tell me. You said intolerance to heat, excessive sweating, tremors, patient has got a swelling, increased appetite. Will he be sleeping in the night adequately? Will he not eat in the night?
Sir, a patient have a complaint of insomnia at the starting. Then after patient taking a medication, and
So that should be added, ma. That should be added. Patient was insomniac. After taking tablets now, she is better.
yes,
So, Florina, you had previously written insomnia, but here also sleep adequate after medications.
Yeah, that's what I asked her. Please tell that one.
Yes. Right, sir. Right, sir. Ritesh bhai, anything on your side?
Yeah. Are you sure that bowels are irregular or regular?
regular, sir. Yes, sir.
Are you sure? Because what kind of bowel irregularities you can see in hyperthyroidism?
Patient have an increased frequency of stool.
So patient is having excessive appetite, loss of weight, and she does not have. She has tremors, but she does not have any bowel irregularities. Very unusual. Okay, go ahead. Now come to the examination, please.
Yes, sir.
Just the summary part. Jailal sir, anything on your side? Modi sir?
Ritesh sir has raised a very valid point. So, can it be something to do with the medication patient is taking? Are you sure patient is taking only carbimazole, or is she taking something else also?
Sir, patient is taking only carbimazole because patient
So,
said
is the patient on any anti-anxiety drug?
no, sir.
Okay, fine. Always ask that part also, because it's a very common practice by physicians to start anti-anxiety, right? Okay.
Florina, what is your observation? Because you said of 2 years this patient is taking carbimazole. Is it right, or is it the appropriate treatment?
Sir, antithyroid drug should be taken for 12 to 18 weeks, sir.
Sorry, I didn't get. What do you want to say?
And then what?
Or is asking something else?
Sir is asking whether the medication going on is fair enough for 2 years, or you would like to, if supposing you start a treatment, how will you treat the patient? Medically.
Medically, sir, I will start the antithyroid drug first, and then if the symptoms were not improved, then I will add the beta propranolol also.
So antithyroid drugs not in propranolol is not a part of antithyroid drugs. Huh?
It should be started, if I am not wrong, it should be started simultaneously.
Obviously.
Anti-anxiety alprazolam may also be started right on the day one. But the second part of the question was, she is taking it for 2 years. Is it correct, or you would like to improvise?
Yes, she is taking only carbon.
So that is fine. Is it according to you? Is it an appropriate, or if it was a chance was given to you, you would have changed that?
No, I will start the propranolol from the starting.
Leave that. Even if the propranolol is taken, or will you allow the patient to take for 2 years?
So supposing your dosage of, supposing the patient is taking neomarcazole, propranolol and alprazolam since 2 years, her symptoms have reduced quite a lot, but still she has some symptoms. Now tell me, what will you do? Will you continue with the
Florin, let me simplify it for you. Whether sir is asking as a surgeon, what will you do?
Sir, as a surgeon, I will proceed with the surgery or the radioactive iodine, because the symptoms were not remission after the treatment for too long, sir.
Now, one more history which you forgot or missed is, was she taking regularly, or she discontinued in between?
Sir, a patient discontinued in between, sir.
Yeah, that is the reason. See, 2 years, do you think, how long will it take for her? Suppose this lady had come to you with the same thing, and you had started, I think if I say a senior process, within a period of 6 weeks to 8 weeks, there will be some improvement. By 6 months, I think it will become euthyroid, depending on the level of the T3, T4. So she discontinued the
Responding to
treatment.
change the drugs. Can you say second line of anti-thyroid drugs other than carbimazole and other things?
Other than carbimazole, lithium can be used.
Lithium can be given. Yeah.
Yes, and then
Commonly, which one is the other drug which is given? And which the physicians are very fond of it. And particularly in female.
propyl
Yeah.
thyroxine.
Yes.
Propyl
Propyl.
thyrouracil.
Huh?
What is the indication of Florina propyl thyrouracil?
Yes, I was thinking Uruben will come in action again now. Yes, this is a
Thyroid,
very important point raised.
it's used in pregnancy in first trimester.
Okay, and what is the specific side effect of propyl thyrouracil?
Sorry,
Side
Specific
effect
side
of
effect.
propyl thiouracil.
it is causes the liver damage, sir. Dose related.
It
What is the
will,
advantage of it over carbimazole?
It is not cross the placenta.
That is fine.
and what is the another
Mechanism of action.
indication for propyl thyrouracil other than first trimester?
Patient who is not tolerating carbimazole.
Yeah, so hypersensitivity to carbimazole.
Yes.
One
Can
more
we
very
continue?
specific is there. One more indication.
Yes,
Somebody-
Dr. Jailal sir is asking one more
What is
indication.
what is the dreaded complication of carbimazole?
Agranulocytosis.
How do you put the patient? When the patient presents to you with some symptom, you stop the drug and do something else. What is it?
Patient presented with sore throat.
Yeah.
When you are giving a prescription today, when the patient will come with a sore throat?
From 6 to 8 weeks.
Very good. It is not immediately. Patient has
Immediately.
to come for after.
So what do? You stop the drug, and what is the next investigation you ask for?
Complete blood count I will do for a
Peripheral smear.
smear.
Is it a dose dependent cumulative toxicity or sensitivity? It is not
The
cumulative toxicity.
answer is there in it.
Even a single dose can cause that. Propyl
Yeah,
thiouracil, the most important is the thyroid storm.
Any drug which causes allergy is mostly due to the sensitivity only, not the dose. Okay.
So thyroid storm is one condition where you use peripheral thyrouracil because it has a property of both. It acts centrally and also peripheral conversion it blocks. So that's why we use thyroid storm. Propyl thiouracil is ideally used. You are very, very well said because it is not entire pregnancy. Propyl thyroid is not indicated only for first trimester. Because the complication is more. Second trimester and third trimester, you can use other drugs. Carbimazole can be still used.
Yes.
Go ahead, ma. Go ahead.
Go ahead.
On examination,
What a huge cell.
So you don't have a general examination.
Yes,
You
sir,
go
yes.
first.
She is searching for that.
By mistake, it has
Yes, there it is.
I have on general examination, I have examined the patient under adequate light and exposure. Patient is conscious, oriented to time, place, and person. Patient is well built and well nourished. Temperature is normal by palpatory method. Pulse is 100 beats per minute, regular in rhythm with normal force and normal volume in right radial artery on sitting position in rest.
Florina, just a minute. You told it is a regular rhythm. The pulse rate is 100. 100 is at the upper limit and rhythm is regular. Are you sure?
Yes, sir.
So what kind of irregular rhythms you can see in hyperthyroidism patients?
Patient have a sinus tachycardia or PSPT. Atrial fibrillation, there is a irregular rhythm were present.
Regularly irregular or irregularly irregular?
Irregular in atrial fibrillation.
Good.
What is other changes in the pulse you can get in a thyrotoxicosis?
In pulse,
What is the pulse pressure?
bounding pulse and pulse pressure were wide, sir.
Right. So what will be the type of pulse you will get?
Collapsing pulse.
Collapsing. That is a possibility. The wide pulse pressure is there. But it is with 100. It is very difficult to make it out. Okay, go ahead.
It will be Florina hyperdynamic pulse due to the metabolism is high. Metabolic rate is high.
Yes.
Is it true, sir?
Yes.
Would you look, I would like to ask the senior professors, sleeping pulse rate, is it important now?
Mm.
How do you do sleeping pulse rate, ma? That is the only bedside clinical indicator to know whether you are treated adequately. The patient is doing fine in a normal euthyroid state, which we were doing before the advent of the drugs, where the drugs sleeping pulse rate was done. But will you do it now? Are you ready for the surgery? How do you look for sleeping pulse rate? Tell me, please.
I will look for sleeping pulse rate while patient is asleep and on 3 consecutive day, and I
Not
will
3, 1, 5 or 7 days.
and then take an average of the.
You give any drug? You give any drug to measure the sleeping pulse rate? SPR chart?
We do not use give
You can give alprazolam.
Indian.
Okay, or phenytoin you can give. So when all the systems are sleeping, the thyroid is hyperactivity. That means the pulse rate will be high. That means your treatment is inadequate or the dose is inadequate. Okay, you understand?
Yes, sir.
When all the systems are put to rest, the thyroid is functioning individually. If the pulse rate is high, it indicates that your treatment is inadequate.
Yes.
Not necessarily that for every, only during your, prior to surgery, when your treatment is complete, you plan for definite surgery, you can look for sleeping pulse rate.
Yes.
Sir, any comments you can please?
No, that is fine.
Ritesh bhai, anything on your side? Continue, beta.
Yes,
Nothing,
sir.
sir. Please continue.
Please continue.
Blood pressure is 118 by 78 mmHg in right brachial artery by auscultatory method in sitting position. BMI is 22 kg per meter square.
What is that kg per meter square, ma? What is that meter square stands for?
It's for height, sir.
Height.
Height is meter. What is meter square, sir is asking.
So we normally use meter square in chemotherapy drugs. This gram per meter square.
Kg per
So
height.
BMI is a unit. It has no specific unit like kg and meter square. This is a formula which you are used to find out the BMI. The weight in kilogram by the height in meter. We never put a formula whenever we put out a report. So BMI, you have to only put a number. If you are putting as a kg meter square, then it gives a wrong
Impression.
suppose a chemotherapy like 1.73 per meter square differs. Antibiotic you are putting per gram body weight. So that is not the way. You just try to put 22. This is the number which is coming. It is not a unit of that. It is only a formula for correcting the BMI. Go ahead.
Carnofsky score of 90. Pulse pressure is 40 mmHg and respiratory rate is 18 per minute.
Next slide.
Palm were moist and sweaty. Standing loop. Tremor is not present. Oral cavity is normal. No clubbing, pallor, icterus, cyanosis, or lymphadenopathy.
So you are saying not anxiety, but palm moist and sweaty. So is it
Anxiety? In anxiety, there is a cold.
No, that is a difference between anxiety, what you are getting normally in an examination, other things, and anxiety, what you are getting in a hyperthyroidism. Hyperthyroidism, patient will be anxious and the palm will be hot. In normal anxiety, the palm will be cold. It will not be hot. That is how you differentiate whether the anxiety is due to because of your examination, because of the various surroundings the patient is having. But my question is, your patient is having a palm is moist, sweaty, but you are saying very categorically patient is not anxious. That means you are a very good doctor. Your examination was very comforting, very soothing, and you have kept the patient in a very position. So she is very happy at your examination. Good, very good. Go ahead, go ahead.
On local examination.
No, here you are putting as a tremor not present.
Yes, sir.
And your complaint says the tremor is there.
Sir, it present tremor is not present.
No, you
After
also never
medication, the
said
tremor part has improved, you say?
Yes, sir. Patient have a complaint of tremor 2 years back. And at present, sir, patient have improve. On examination, there is no tremor.
that is not the summary which you have given. You have said the certain things has reduced, but tremor you have said it as a continuously it is present in the history. Okay, go ahead.
Florina, it is written that oral cavity is normal. So what will you examine in oral cavity?
Ma'am, I will look for two things. One is a lingual thyroid. And by ideal examination, I will look for the vocal cords.
Anything more important that ma'am has asked specifically in hyperthyroidism patients?
In general, Florina, in thyroid, if you are asked to examine, I'm telling in general, one is you look at the size of the tongue, the macroglossia and hypothyroidism. But since hyperthyroidism, we look for tongue tremors,
Sir.
tongue fasciculations.
Yes.
And if you are asked anything else, you look for any oral mucosal neuromas for MEN syndrome. That is in general, I'm telling. But in this case, as madam asked, you look for tremors and fasciculation.
Yes.
How do you look for tremors? How do you look for fasciculation? Tongue inside or outside? Which do you do? For both, you keep it inside.
In tremor, I will ask patient to take tongue out with support on the lower lip. And
look for fasciculation. You have to keep inside and look. Fasciculation is minor movements, which
What
can
is the
be
difference
appreciated
between
only when.
fasciculation and
Pardon, sir?
No, what is the difference between fasciculation and tremor? Fibrillation, fasciculation, tremor. All are same or different?
Florina, it's for you.
Sir, tremor is an involuntary shaking of the tongue, where fasciculation.
In general, I am asking the definition difference between fibrillation, fasciculation, and tremor. All are involuntary only. You can't produce voluntarily, you can't produce a fasciculation. Okay, depending upon whether tremor is entire group of muscles are involving, the group of muscle fiber is involving is a fasciculation. One muscle fiber is involving is a fibrillation. Go ahead.
Can I ask you, can I request you one thing, Florina? Just as you read Das, kindly read Hutchison also. As far as you may be a MS postgraduate, but for these sort of small questions, kindly read Hutchison also.
Yes,
okay.
Yes, sir.
Just an advice.
Advice you should definitely follow.
Yes, sir. Because a very good book, sir.
A very good book. Very good book.
Very good books.
Do you think clubbing can be there in a thyrotoxicosis? What are the cutaneous manifestation of a thyrotoxicosis you can get?
Clubbing is present in patient with primary thyrotoxicosis.
Is it really a clubbing? What is the difference in the clubbing of normally what you get in the thyrotoxicosis? You get acropathy, no?
Yes.
Is it acropathy and clubbing are the same?
In acropathy, there is a enlargement of distal part of the whole toe.
It is not on the terminal toe. Part. you get a newborn formations will be there. It is not due to the just accumulation of the fluid and fibrosis. It is not happening. There is a clubbing is a different mechanism, pathogenesis. Acropathy is another pathogenesis, but it looks similar. When you are seeing that, you can. What are other cutaneous manifestations you can get?
Pretibial myxedema.
Due to what?
Due to deposition of the glycosaminoglycans like hyaluronic.
What is what it looks like? Pretibial myxedema. Why it produces edema? You are talking about edema.
Due to hydrophilic nature of the
Very
glycosamine.
good. Yep. So when we expecting you to asking a question, you must put, because you know the answer. You are studied well. You know the answer. So put that as an important thing. No? Don't just jump. Very good answer. Okay, go ahead. Next you can go.
On local examination, I have examined the patient under proper light and exposure in a sitting position. From
What you are examining? What do you mean local examination?
Local examination of what?
Of neck.
So that you should put neck. What you are examining? It's a local examination is a general terminology. You can put local examination of the neck or examination of the neck. That is a better terminology to put.
Yes, sir.
Okay.
In sitting position from front and behind of the neck. Inspection. Butterfly shape, diffusely enlarged swelling present in front of the lower neck. Horizontal extent on both side beyond the sternocleidomastoid. In vertical extent from superior border of thyroid cartilage to suprasternal notch inferiorly. Right lobe approximately 6/3 centimeter and left lobe approximately 6/2 centimeter in size.
When did you saw the butterfly last? Have you seen the butterfly?
Thyroid is butterfly shaped, but when you examine, you can say diffusely enlarged. That will be the better word, ma.
No, butterfly will have a central part. The pyramidal lobe will be also enlarged.
Florina, show the first picture.
Not simultaneously same. So
No.
unnecessarily don't bring in that. For undergraduate, it is fine. But for postgraduate, you describe what you are seeing.
Yes.
Pyramidal lobe enlargement is a feature of what kind of thyroid mass? It is a feature of Hashimoto's thyroiditis. If you have a good pyramidal lobe and a good bilateral lobe, so more in favor of Hashimoto's than in favor of a Graves' disease. Graves' disease, you are going to get a diffuse enlargement of both the thyroid lobe. That is a better, you can explain. In examination, we are interested in more of scientific presentation than an adjectives which we are using. Good, go ahead, ma'am.
Swelling move with the deglutition. Surface is smooth, well-defined margin. Inferior border is visible. Overlying skin is normal. No visible scar, sinus, or visible pulsation over the swelling. No other visible swelling in the neck.
You said overlying skin is normal. That is enough, ma. What is the visible scar? What are the sinus you get in that area? This is routinely everybody. Please don't put it. Okay. When you
What
say
sinuses you are going to get in that region?
No, you will get any branchial sinus or anything tubercular sinus.
Tubercular
When you
sinus.
said skin is normal, you can leave it, ma. If the examiner asks you what are things to look for a scar or sign, otherwise you leave it like that. Okay. So basic question: why does that swelling move with deglutition?
No need to add on to that. When you said the skin is normal, absolutely it is fine. And for the sake of all of the PGs also, can you say that why the thyroid is moving with deglutition?
Due to while deglutition, movement of the inferior constrictor, which is connected to cricopharynx, which is like Berry's ligament connected to
You are tracing from reverse to anterior. Okay, fine.
See, the investing layer enwraps the gland, gets condensed posterolaterally, forms the Berry's ligament, joints gets attached to the cricoid cartilage. The inferior constrictors like the cricopharyngeus, the thyropharyngeus, during deglutition, that are the muscles which pull up the cricoid cartilage, or when it moves up. When it moves up, it moves the Berry's ligament. When it moves the Berry's ligament, the thyroid moves with deglutition. This is how you have to say, okay?
What
Yes.
are the deep fascia? Layers of the deep fascia?
Pretracheal fascia, prevertebral fascia.
Only two fascia.
In
You have three layers. Investing layer is one. It invests two muscles, two glands. It is not investing the thyroid. Thyroid is a separate middle layer. That is a pretracheal fascia. That is investing the thyroid. That forms the Berry's ligament. That is a prevertebral fascia. Is it moves with up? Is it moves side to side? Thyroid is moving with side to side.
thyroid will move to side to side along with the wall trachea and wall component.
What is trachea? Oh, it is attached to trachea.
Sorry, sir.
Is it attached to the trachea? Fixed to the trachea?
By
Thyroid can move side to side, ma. You go and push that mobile. If it is not moving, that means it is fixed to the prevertebral fascia. That is a rare form. Okay, go ahead.
Ritesh bhai, anything on your side?
Can you tell me which are the thyroid swellings which doesn't move with deglutition or has got a restricted mobility?
thyroid swelling, sir.
Yeah.
In case of riddle thyroiditis, we do not move with the deglutination, or in case of advanced malignancy, thyroid swelling will not move with the deglutination.
One more is recurrent thyroid. Recurrent thyroid swellings, okay?
Yes, sir.
They do not move. They move with difficulty, but not much appreciated.
Yes, sir.
What is the importance of telling that the inferior border is visible?
To rule out the retrosternal goiter, sir.
What are the retrosternal goiters, you know?
Sorry, sir.
How do you classify retrosternal goiter?
Suprasternal goiter, suprasternal retrosternal goiter, plunging type of the retrosternal
It is otherwise called the primary and secondary.
primary and secondary, yes, sir.
Primary occurs from the thorax,
Thorax
from the
and
retrosternal region. Secondary,
from
then
the
the above, then the neck swelling. It goes down. Substernal is one. Number two, next is plunging. The third one is intrathoracic goiter.
yes.
Okay.
What is the difference between retrosternal and plunging?
Plunging present in over the cervical, and in plunging there is it is start from the mediastinum and goes to neck.
Start from mediastinum, goes to neck.
Or is it
The
the other way
answer
around?
is clear, ma. The swelling
What
is
do you mean
there.
by plunging?
It plunges into the retrosternal area, and when the patient swallows, it comes out.
Yes, sir.
You understand me? It plunges into the retrosternal area. When the patient swallows, it comes out.
Yes,
That's what the sir is asking. What is plunging?
So retrosternal, you can see still visibly. You can see at least 50% of the thyroid. You can see. Here you will not.
Retrosternal part will be inside, part
At
will be
certain
outside.
moments, it comes out.
Yes.
Okay.
Blood supply to retrosternal goiter.
Retrosternal goiter, sir, in
Is it the same like a normal thyroid or a different?
in mediastinal goiter, there is a supply from the mediastinal vessels.
No, that is a secondary. Normal retrosternal goiter, what you are seeing.
What about the plunging variety and the other variety?
He said substernal plunging, and he said
In substernal is supplied from the thyroid vessel only, sir.
So the normal vessels itself supplies.
normal vessel itself supplies, ma, because it is arising from the neck and going into the retrosternal extension due to the huge enlargement. I think the blood supply
That
is
is
the same.
advantage of surgery. You know, when you
Correct, sir?
ligate normal vessels, then it is you can easily take it out.
Jayala sir said correct. The normal vessels only is supplying, isn't it?
Yes, sir. Yes, sir. Absolutely.
Only if it is the primary is in the primary retrosternal goiter, you get it from the mediastinal vessels. Okay.
It's very, very rare. Okay.
Very, very rare.
Go ahead, ma.
Go on, please go on.
PRM, sir, Ritesh bhai, anything?
Anything else, please? Hi, sir. We are asking, we are bombarding.
No, sir, it is fine. We
We're
need
not
it.
bombarding, ma, Florin. It is just correcting you and making you more of knowledgeable. That's all. Okay.
Next slide.
Yes. On palpation, inspectory findings were confirmed with the palpation. Temperature over the swelling is normal and the swelling is non-tender. Swelling move with the deglutition. Getting below the swelling is possible. Horizontal extent is from medial border, cannot palpate separately from the sternocleidomastoid. Vertical extent from the superior border of the thyroid cartilage to suprasternal notch. Right lobe is a 6 by 4 centimeter and left lobe is a 6 by 3 centimeter in size. Smooth in surface. Form consistency is firm. No, not fixed to surrounding structure. Side to side mobility is present. No other palpable swelling in the neck. Bilateral carotid pulsation palpable at the normal site. Trachea is centrally situated. Thrill present over the upper pole of the swelling.
Your first statement says temperature is normal at thyroid. But the general examination, you said patient is moist hand, sweaty, and you are also saying there is a thrill in the thyroid. Do you think the temperature will be normal?
Yes, sir, somewhat increase in temperature. Present, sir.
Surgery is also like a mathematics. Always 1 + 1 is 2. So it's always coincidence. Already the patient is in such a tachycardia. To the extent she is having a thrill, that means there is a lot increased vascular blood supply. Vascular blood supply is there. So there is definitely there is something more you could have appreciated on the swelling region.
On auscultation,
Go to the previous slide, ma.
Sorry, yes,
The previous one.
yes.
Now, when you said inspectory findings are confirmed, this, the third, fourth, all statement is not necessary. One is your palpatory findings. Is it smooth surface or nodular surface? Go to the next one. Consistency.
Yes, sir.
What do you mean by thyroid paradox?
Is it nodular or thing, all this thing? Now, in this one, you are not mentioned the plane of the swelling. Any swelling will have a plane, isn't it?
Yes, sir.
Do you know any swelling which is in the subcutaneous plane which moves with deglutition?
How do you find out the plane of the swelling here?
Because there are some swellings which move with deglutition. Can you name them?
Some subhyoid bursitis, prelaryngeal and pretracheal lymph nodes.
So prelaryngeal, pretracheal, are they deep to this deep cervical fascia or superficial to the deep cervical fascia?
They are superficial to deep cervical fascia.
So thyroid, is it deep or superficial?
Thyroid is deep to deep cervical.
So you should know the plane of the swelling, isn't it?
Yes.
How will you look for the plane of the swelling?
This is a little controversial question, ma. You cannot say it is deep to cervical fascia. It is always better to say it is within the cervical fascia.
Yes, sorry, sir.
Your deep cervical fascia has 3 layers. So
yes, sir,
is the thyroid is within the pretracheal fascia. Never you say superficial or deep. Then you will not be able to. So it is always anterior to the vertebral fascia. It is always below the investing layer, in between the pretracheal fascia. So one is like that. Second, no other test is there clinically to find out the plane of the swelling, because you cannot put strap muscles into contraction voluntarily. You cannot put both the sternocleidomastoid simultaneously together for contraction. You can do one sternocleidomastoid, but not both. When the both are put in together, the function is peeping function. So head should be elevated and spread forward. That is also cannot be tested. So the only test you can do is a swallowing with deglutition. Just because thyroid is moving with deglutition, you can very confidently say the plane of the swelling is within the deep cervical fascia.
The stretching of the deep fascia, sir.
That is very, very unusually, sir. Clinically.
Just exam, sir,
Practice,
they're asking.
they say.
Modi, sir, what do you say?
Pardon, sir?
Stretching of the deep fascia
Yes, sir.
to know whether the thyroid is deep to the deep cervical, is enclosed in the deep cervical fascia. How will I look for the plane of the thyroid swelling, sir?
So usually the thyroid swellings move up and down, and we have to, for students also, make the patient's neck horizontal, a little bit flexion and a little bit extension, so that you can check for the swelling movement in all direction, in all kind of neck positions, and then you can make it out whether it is retrotional or not retrotional. And if it is mobile up and down freely, and then it is usually deep to deep fascia, it is in the pretracheal plane.
But lymph nodes also are there now, sir. The
Lymph nodes are there in the lateral neck, sir. We cannot palpate the central neck lymph nodes, but we can palpate the lateral lymph nodes. So they are present over the carotid sheath, which is another component of deep fascia.
It will not move.
Lot of controversy to know whether is thyroid. How do you look for the plane of the thyroid?
So only with the moving with the deglutition is the feature to say it is a thyroid is within the deep fascia. I will always use the word within the deep fascia than deep to deep fascia, because I believe vertebral fascia is also part of a deep fascia. So it is not never posterior to that. So it is between investing layer and vertebral fascia. So it is a within the deep fascia is a better answer.
Okay, sir. Still you are learning, Florin, from Jailal, sir.
Why it is necessary to know about the movement apart from movement with deglutition?
To know the fixity to surrounding tissue in
Which surrounding tissue?
To muscle.
Which muscle?
Sternocleidomastoid.
Okay.
And to
so in an extension of the discussion which is going on, the problem will be that when it becomes fixed to prevertebral fascia, then it becomes fixed. That's why when it is deep to investing layer but superficial to prevertebral fascia. So when it becomes fixed to prevertebral fascia, it becomes very fixed. So rather than movement of that kind, movement relation to sternocleidomastoid is more important. Relation to carotid is more important. Because anyway, when it becomes fixed to larynx, clinically it is very difficult to differentiate because it will move as a one apparatus when you will be move with deglutition. So only fixity will be seen by the in fixity to prevertebral fascia.
If it is fixed to the prevertebral fascia, the side-to-side movement will be restricted. You will not be able to move the side-to-side.
Yes, exactly, sir. Thank you. Please continue.
Continue.
Bruit at the upper pole of the swelling is present.
Florin, don't use word bruit. It's a bruit. T is silent. Yes.
Why do you look at the upper pole, ma?
But where is the percussion findings?
Why do you look at the upper pole, ma?
Upper pole due to superior thyroid artery. It is a superficial, and it provided the branch to superior pole in umbrella-like manner. In this case, there is a increase hyperdynamic.
Why not inferior pole?
Superior.
What is there in the inferior pole?
Sorry, sir.
The question
what is there in the inferior pole?
Now, sir is asking why not the inferior pole?
Sir is asking what is at the superior pole, there is superior thyroid artery and superior thyroid vein. Yes. What is at inferior pole of the thyroid lobe? Which vessel is there?
Anterior thyroid vein.
Not artery?
Inferior thyroid artery.
Is there at lower pole?
Why don't you hear the thrill at the lower pole then?
Because the inferior thyroid artery is deep in nature, and
inferior thyroid artery is not
do we ligate the inferior thyroid artery or something else?
No, we will ligate the branch of the inferior thyroid artery.
Florin, you are confusing yourself and others. Remember, the lower pole contain only inferior thyroid vein. which both inferior thyroid vein drain into left brachiocephalic trunk. So what you find at the lower pole is only vein. The artery comes from the subclavian,
Yes,
right?
yes, sir.
The thyrocervical trunk of the subclavian, which comes, so inferior thyroid artery comes from behind the carotid artery and enter posteriorly. And before entering, it divided into multiple branch, which is covered by whole thyroid lobe. So to assess the inferior thyroid, it is practically impossible clinically outside. Whereas the superior arising directly from carotid, it has a short course, relatively superficial, major blood supplier of thyroid lobe, and it divides into multiple umbrella-like vessels. And patient already has a metabolic disease, so has a hyperdynamic circulation, which gives typical thrill and bruit in the case. So do not confuse, the lower pole contains both.
Good, very good explanation.
Yeah.
Excellent, sir.
Thank you. It's okay,
Ritesh,
continue.
you were asking about percussion.
Yes. She has not told separately about percussion. She has written only the trachea centrally situated, but I would like to know more about percussion findings.
Definitely, sir. It is very important. Even I missed it.
Please answer me. Why you didn't
Yes.
do percussion?
Percussion I will do over the upper part of the sternum in over the manubrium sterni to look for any dullness were present or not, sir.
Oh, this
With how many fingers you do percussion?
Sorry.
With how many fingers you do percussion over the sternum?
With sir 2 finger, sir, from one hand.
See, Jalal sir is nodding his head. see carefully. With how many fingers you do percussion over the sternum? It is different than other body areas. It is a direct percussion. It is a direct percussion. You need only and only one finger tapping over the manubrium.
Yes, sir.
It differs from other percussion, no? Direct percussion. Okay. So why do you want to percuss?
To see any dullness were present or not, which is present in the retrosternal goiter. Dull.
Is it only that? Anything else also? Suppose you don't have a retrosternal goiter, but you are getting a dull node. What do you think?
Anterior mediastinal tumor.
Tumor, thyroid node is there. Can be a node also. Anything which is there on that. Go ahead. So how did you hear the bruit? How you are sure that it was a bruit you are hearing, not the normal heart sound you are hearing?
I will hear the bruit by the bail of the stethoscope over the upper part.
How was it? What sound you heard? Is it a continuous sound you heard or a systolic like murmur you got?
Bruit is like a systolic murmur. Like a continuous murmur.
So you are able to appreciate that. Have you done that? Are you
Yes,
sure
sir.
that you are appreciated that?
Yes, sir.
Because you had a very small thyroid swelling with a thyroid nodule. It's very small. It is long standing. Getting it to the extent of getting a bruit, it is little difficult at this point. But okay, but if you are appreciated, it is fine. What else you appreciated when you are auscultating?
Position of the trachea.
Very good. You heard the breath sounds also.
Yes, sir.
Fine. Okay.
On cardiovascular system.
Have you examined the eyes separately?
Yes, sir. I have examined the eye specially at the last.
Jalal sir, if you permit, then shall we go to the eye examination directly because it is more important in this case.
Yes, sir, please.
Yes, I actually told her to take eye before cardiovascular, but I think there was some misunderstanding. Obviously, and this is message, you must take it before going for systemic examination. It is a part of local examination.
Part of the examination.
At the end of the local examination, at starting also you should say that, sir, I'll be examining the eye at the end of the local examination.
That also I told her.
So continue, beta. Continue.
Okay, no problem. That is what the learning process is all about. Yes.
Sir, on eye signs, patient have a staring look with infrequent blinking, infrequent blinking, present with the wide palpebral fissure, On left eye, eyelid retraction present with visible lower and upper sclera.
What is the cause of eyelid retraction in this case? Why it happens?
Due to sympathetic overactivity, there is a autonomous part of the levator palpebral superioris, which is a Muller muscle, which is a increased contraction of this muscle, which causes the lid retraction.
Very good. What this sign is known as?
Von Graf's sign.
No.
Okay.
You should know, Florina, there is no excuse for this. You are supposed to know all the signs.
The name of the lid retraction.
There are two signs. One is lid retraction and one is lid leg.
The lid leg is called the von Graf.
And what is lid retraction?
That is a Stelvex. It is known as a Stelvex sign, right? And collectively, these two signs, will it be present in all hyperthyroid case?
Or is it only in Graves' disease?
Yeah.
Sir, in a hyperthyroid case, if the patient have a Graves' disease,
No, do not confuse, please. The question is very specific. Will it be present in all hyperthyroidism or will it be present only in a Graves' disease? They are different things. Don't confuse them.
Secondary thyrotoxicosis, will you get this sign?
In secondary thyrotoxicosis, I will get the lid retraction and lid leg, sir.
Very good. Why?
Due to sympathetic overactivity, we are present in secondary thyrotoxicosis also, sir.
Muller's muscle is, it is better not to say it's a part of the levator superior. It is a separate muscle. It is there in the posterior part attached to that. It is a muscle attached close to the levator superioris, but having a sympathetic overactivity.
Sympathetic overactivity.
What is ptosis?
Ptosis is seen where there is a patient have a compressive symptom.
No. What is ptosis? Answer the question. Do not give one step ahead. The question is what is ptosis? Why there is ptosis is a different question. What is ptosis?
The drooping of upper eyelid.
Exactly. And this is for all PGs. Understand the question. Don't try to answer what you know. Let examiner ask second question. You will have a credit of 2 questions. Okay.
And always try and give, sir is very right. Try and give only very specific answer and don't try to beat about the bush. It creates a very bad impression. Maybe you are trying to outsmart the examiner or you are trying to save the face, but don't do that, please.
Florina, can you name a single condition where there is a ptosis in hyperthyroidism? It may be some other disease also associated, but where there is a ptosis in hyperthyroidism rather than lid retraction. Can you name a single disease, please? Single condition.
Excellent.
Single condition which has both connection with that.
Yes.
Fundamentally.
We have discussed that in this also.
In hyperthyroidism, sir?
Yes. In
the patient has hyperthyroidism.
Any association where there is a ptosis.
You can remember a great actor.
No, sir.
This is better. Say loudly and clearly.
No, sir.
I don't know, sir.
Good. So in conditions of myasthenia is an autoimmune disease, Graves is an autoimmune disease. They both may coexist. In case of Graves' myasthenia, there shall be ptosis.
Yes.
So hint was for Amitabh Bachchan, by the way.
Yeah, that was a great actor. No? So this
he had a myasthenia gravis.
Yes,
so you can have a diabetes, type 1 diabetes, thyroidism. All this can go together.
Yes.
So look,
because the names of actor has started. So do you know name of any actress which was at her peak in 60s and 70s and her career was abolished because of hyperthyroidism?
She must know because I always quote this.
Good.
I always quote this. She must know. I don't know whether she remembers.
She was at her peak and her career was abolished because of hyperthyroidism associated eye disease.
And the point I can give you hint is that she always used to wear dupatta around her neck. Never shown without dupatta if you go and see the movie. Because of the swelling, she was never showing the neck.
Neck part, right, sir?
She was sadhana.
Yeah.
I always go to my residents.
So,
Okay, go
I
ahead.
think your students are very good. They are not remembering what you have said about actor and actress. They are only knowing the subject.
I don't like that. You should know everything. That will improve your surgical skills also.
Florina, when we are discussing the eye signs, what are the symptoms you should ask during the history regarding the eye?
Patient complain of excessive watering from excessive tearing, or any chemosis, or the patient have any pigmentation in the eye.
Not
Very common.
pigmentation, but redness.
Earlier occurrence.
Blurring of vision.
Blurring, or what is diplopia?
Or diplopia.
What do you mean by diplopia?
Diplopia, there is a convergence of the eye. It's not possible. Double vision is
So
there.
you can see two things at a time. What do you mean by double vision? If you can see two things, that is always better, no? You can read two subjects at a time.
The same subject.
As you said earlier, no, it's a blurring. The two eyes converge with each other. So you will not get a complete convergence. It is either horizontal diplopia or vertical diplopia, depending upon which muscle is involved. So you will not be able to see. It's like something similar to the blurring of the vision, what you are going to get. So that will be happening with the symptoms.
And why there is watering of eye?
Sorry, ma'am.
Why there is watering of eye or excessive tearing?
Due to edema.
No, it is due to dry eyes. And why there is dry eyes? Because patient cannot close the eyes properly.
Yes.
So how do you get edema in the eye?
In edema of the conjunctiva is developed due to congestion, due to obstruction of the venous and lymphatic outflow due to orbital pressures.
Now, how do you get retroorbital pressure is increased?
Due to increase in the fatty tissue, lymphatic infiltration, and in fatty tissue there is a increased water content.
No, is it? You think that exophthalmosis due to the fatty tissue is there?
What else is there?
Now, what is the mechanism, pathogenesis of exophthalmosis? How it is starting? In a Graves' disease, what is happening there?
In Graves' disease, there is a increase in the cytokine release, like IGF-1, which
cytokine is coming from where?
Due to
it is an inflammatory process. So there is accumulation of the lymphocytes. So that increases cytokine that stimulate the accumulation of
glycosaminoglycans.
Okay, that is hygroscopic. That
yes.
So that's a sequence which we pathogenesis and how it is starting with that.
Yes.
Okay, what other eye signs you have checked?
I will check for the lid retraction, lid lag, visibility of upper sclera.
How will you check lid lag, lid retraction?
Lid lag, I will hold the patient head with the one hand, and then stabilize the head of the patient. Then ask patient to follow the finger from from above to below.
No, you have only two hands, no? You said one stabilize and hold the head.
Yes, sir. One stabilize the head of the patient, and by using other hand.
What distance you keep the pencil from the eye of the patient?
How far from the patient?
1 feet. Exact, yes, sir, I don't know.
This depends upon the focal length of the patient. Everybody, what is the best focal length for us to study anything? It's a 25 centimeter. So that is also an ideal for always you are doing an examination also and do the focal stuff. Only when you are doing the convergence test, you take the pencil from 1 meter distance to the 25 centimeter distance. You are bringing it. Otherwise, you are doing this. So when you are holding and keeping very close to the patient, it may be little difficult, but it's fine. What you have said is fine. But you must know where you are going to keep that your hand or the movement of the hand. Look.
Yes, sir. Then I will look for the wrinkling of the forehead, and then any diplopia while
Why there is a wrinkling of the forehead?
wrinkling of the forehead.
Why do you want to wrinkle, Amma? Normally? See, normally when we are looking at something, our upper conjunctiva is covered, ptosis. So when we are wrinkling, the upper lid is moving up. So that allows you to see it normally. For these people, there is a upper eye is visible. There is no need for them to wrinkle. That is the reason why there is no pathological, no muscle is involved. There is no defect in any of the particular muscle is there with us, the wrinkling absence. It is physiological because we normally do physiologically wrinkling just to see things very clearly. That is the upper eyelid is to visualize. But here it is automatically that eyelid is exposed. They don't do the wrinkling. There is no particular muscle is involved here.
Yes.
Sir, is it not the frontal belly of the occipital frontalis, sir?
No, sir. No, sir.
No, sir.
There is no anatomical damage and nerve injury is there, sir.
Yeah.
No.
There is a one another explanation which was given. Yes. I don't know actually. I'm sure.
I want to learn, sir.
The point is that a patient has an exophthalmos, what we call as a proptosis. So eyeball has beyond the superciliary arch. So he or she doesn't have to work hard to retract the upper ciliary arch. So the wrinkling is not there.
Okay. It's exactly right, sir. That is a answer. It is there because there is no particular muscle is involved here.
It is not needed. That is the point. So as sir has said. Thank you.
Thank you, sir. I learned today. I'm still learning.
We are also learning.
We are all learning, sir.
Thank you, Jagalal, sir.
Continue with the eye science, Florina. Ritesh bhai, anything on your side?
No, sir.
Continue with other eye science. Jalal sir has asked you about other eye science.
Only know this, I mean, not due to other causes of retrobulbar tumor or other things. It is only due to the exophthalmosis. This lid lag and lid retraction, other things, eye science. Exophthalmosis is due to thyroid or other conditions. How will you differentiate?
Florina, sir is asking very specific question in simple word. How will you differentiate between exophthalmos and proptosis? Usually the proptosis is used for the protrusion of eyeball other than thyroid disease. That the sir is asking. Am I right, sir?
Yes.
Yeah.
There is one sign, ma.
Associated with headache in case of cavernous.
No headache.
G, there's a sign called, if you don't know, Gifford sign.
Gifford sign.
Yeah.
If
you are able to avert it, it is. Now tell, I gave you the answer. If you are able to avert it, what is it? If you are not able to avert it, what is it?
In case of exophthalmos, upper eyelid can't be averted.
Cannot be.
Cannot be. You are telling the opposite.
Your Muller's muscle is already contracted, no? So you will not be able to avert.
Cannot be.
So in other things, the Muller's muscle is not normal. So you will be able to.
Yeah.
Yes.
So did you understand? Yes, sir means did you understand? Repeat it, please, because I have doubts.
Sir, in patient with hyperthyroidism, there is a contraction of the upper eyelid already. So upper eyelid can't be everted in patient with hyperthyroidism and not in the other causes of the proptosis.
Okay.
Right.
How did you find out patient has exophthalmosis?
Patient visibility of
what is that method called? What is that way you are examining?
Visibility of upper sclera is called the
the method, ma. Ask the patient to sit in the chair. What is that method called?
Neff-Ziegler sign.
So you have done that?
Yes, sir.
Because these
Yes,
are very
nowadays-
rare opportunities you get. So you must always practice that test with the normal and this type of people. Simultaneously, you should examine a normal individual also, so that it will be always constantly you can remember that. Okay, fine.
Yes.
Is this patient still with you?
Sir, patient at present, sir, is not
No,
present.
if
It
it
is at
comes, if it comes, you do all this what the sir we are telling, okay? Try to effort, Gifford sign. Because nowadays, thyrotoxicosis with eye signs, what myself and Jailal sir or Modi sir or Apurva sir saw is not seen much. We have come down. It has come down. It has come down. To be honestly speaking,
True,
do you
sir.
agree with me, sir, Apurva sir?
Yes,
You are
sir,
right.
absolutely right. So
Yeah.
nowadays
When
the
you get-
patient come early to you.
Yeah, when you see
So
this
they
case,
develop such.
when you see this case comes again, kindly do all these tests. Kindly take a photograph and keep it for you. Tomorrow, when you come to the same forum as a teacher, you can teach. Okay?
And so to the UG students also.
Yes, madam. Yes, madam. we don't see much of cases. How about you, madam?
Yeah, yes, really. Because of,
So,
I think because of awareness only, they
all
come
these
early. Yeah,
drugs were not available much in the hospitals when we were studying. But
yeah,
after
right.
the invent of the drugs and the patient's awareness, all this has come down.
Yeah, right.
So this case, Florin, you please, if it comes, take all these pictures and keep it as personal in your laptop. Do the Gifford sign, do the Napsicus method, demonstrate, and keep it with you. Okay. Okay, ma'am.
Anything more on the eye sign, sir, Ritesh bhai?
Now we'll
No,
go
sir,
back.
I think, sir, so much time has gone, so we should go directly to the management. It will be better.
But
Yeah,
sir,
please.
I mean, it is a fascinating thing, sir. As Srinivasan sir said that we are still learning.
Definitely, we all are learning, sir.
Definitely, sir.
Okay,
Go ahead for
Jala
the
sir, shall we move
management
on?
side.
Uriben?
Yes,
there's
yes,
a-
we can go. Yeah.
There is a famous quote by William Osler. He said, "A doctor is a student till he dies. If he
Lifelong
ceases,
learner.
if he
Yes, sir.
ceases
That
to
is why
learn, if he
that is why we
ceases to
practice,
learn,
sir. That is why we
He's-
practice.
if he ceases to learn, he is declared dead." So that's why, please, sir. Florin, don't get upset. These are all points we are giving for you to correct yourself. Okay.
I think Florina's a very famous number, a very peculiar number is 2 years ago. So
Yes, sir.
for all she has put 2 years. Fine, ma'am. Go ahead for the management. How you are going to manage?
Right.
Yeah, leave this, man. What is the diagnosis, ma?
My provisional diagnosis is primary thyrotoxicosis.
You say primary thyrotoxic. You cannot say like that. A thyroid swelling, uniformly diffuse enlargement of the thyroid swelling, probably with. So you have to see thyroid. They say you have 3 diagnoses. One is anatomical. Is it diffuse or nodular? If it is nodular, it is single or multinodular. Here it is a diffuse. Anatomical,
This is for all the postage.
physiologically, is it euthyroid, hyper or hyperthyroid? Hyperthyroid. Pathologically, is it malignant or neoplastic? No, nothing is there. So you can say non-toxic, non-malignant, diffuse goiter.
Yes.
Probably Graves' disease.
For now, one simple question. You said it's a diffuse goiter. That is why you are putting it as a primary. Suppose there is few nodules are there in that thyroid gland. Will you still call it as a Graves' disease or not?
Yes, sir. I will call it Graves' disease.
Still, you can get a nodule. It is depending upon as the days continuous, it can get a nodular formation also. But normally we say it's a diffuse goiter. For postgraduate should know, nodules can be also present in the primary.
Yes. Yes, sir.
So how you are going to manage, ma? How you are going to proceed?
First of all, I will do a thyroid function test, especially a serum TSH for this patient, and look for
Normal value.
normal value of TSH is 0.5 to 5.
5 what? Kilogram.
Milli international unit per ml.
Good.
Okay. So you are only going to do the T3, T4 and free T3, T4 and TSH.
Then I will do free T3 and T4.
What is reverse T3?
Reverse T3.
You heard the term reverse T3? You are checking some books or
No,
what?
I will remember.
Okay.
So do you know or you don't know? Sir will say.
No, it is fine. So when you have two molecules are joining, 3, 5, 3 dash, 5 dash. If the 5 is removed from inner circle, one molecule is removed, then it is a T3. If it is outer circle is removed, it's T3. If the inner circle 5 is removed, it is reverse T3.
Any other specific blood test you would like to do in this patient for thyroid? Any specific blood test for thyroid only?
Serum calcium?
For thyroid.
No specific
You are
only
having
thyroid. Any
T3,
Only
specific
thyroid.
thing.
How will you come to know that it is a Graves' disease?
That is diagnostic rather, I would say.
Yes.
Serum anti-thyroid antibody.
Which
Okay.
antibody?
Not,
Which
not
antibody?
which one?
Anti-TSH receptor antibody.
What do
Will
you
you
call
take
it,
the
beta?
reverse antibody?
What is that known as?
You are correct. It is TSH receptor antibody. Its other name is thyroid stimulating immunoglobulin, and short it is known as TRAB, TRAB.
TRAB.
Okay. So these are the blood tests. Specifically, you would like to see any role of any imaging study in this patient?
Sir, thyroid uptake scan.
Sir is asking any role of any imaging technique in this patient.
Imaging, sir, ultrasound, sir.
Good. So it is a high resolution ultrasonography for thyroid. And what is the role of uptake scan in this patient?
Role of uptake scan where there is a confusion in the diagnosis. In a patient with the Graves or patient have a multinodular goiter. In a case of
Graves and multinodular goiter, we
Not-
don't do. Graves
not
and
multinodular goiter.
hyperthyroidism. What is transient
Madam.
hyperthyroidism?
sorry, sir.
Transient hyperthyroidism. You are getting a value, blood value, T4, T3, T4 will be rise and TSH will be low. So one sect is mainly, it is a thyrotoxicosis, Graves' disease. Another 20% of the people can come to you with a transient hyperthyroidism.
What disease where the thyroid function varies from hyper to normal to hypo?
Sir, in case
Triphasic disease.
Hashimoto's
All thyroiditis, most of this will be
Almost
a triphasic
all, but
disease. At the stage of hyperthyroidism stage, the patient, the blood test will be T3, T4 will be high. And how will you differentiate that from the Graves' disease and this? One
No,
is your
sir.
antibody test.
Sir,
The
ask-
antibody is
sir,
specific
ask one
for Graves'
question.
disease. Another is a peroxidase antibody that is more specific for Hashimoto's.
Yes,
So
sir.
there the
People.
uptake scan role is playing. What will be the finding you are going to get an uptake scan difference?
In uptake scan, in Graves' disease, there is a diffuse uptake were present in thyroid gland. In case of thyroiditis, there is a no uptake in.
Why?
Only diffuse uptake or another anything else?
You put it the other way around, that in diffuse, it is the over, it's a warm nodule, the whole thyroid uptake is more, whereas in Hashimoto's, the uptake is not more. And why it is like that?
Actually less.
The
Why?
Hashimoto's, initially you'll have Hashimotoxicosis. Okay.
Yes.
Hashimotoxicosis, where there will be hyperthyroidism, then it becomes normal and it will go for hypothyroid. That is the reason why in Hashimoto's you don't operate.
So one question, sir. Sir, one question.
Please, sir.
What is the difference between Hashimotoxicosis and thyrotoxicosis in pathophysiology?
Sir, in Hashimotoxicosis, there is in Graves' disease, there is a increased function of the thyroid gland, and in case of Hashimotoxicosis, there is a destroying of the cell which causes the hypertoxicity.
Very good. Follicles are destroyed, so it is at a time it is coming in that. So
Right.
that is why the uptake scan is playing a major role here, where it will be taken. When you will say it is I mean, the uptake is good, above diffuse uptake. What percentage uptake you call? Okay, that's fine. You go.
What is normal uptake? What
Sir,
is
please
increase and what
give
is
the answer, sir, please.
Sir, in nodules, sir, if it is present more, it is a hot. If it is less, no uptake, then it is a cold. And if it is normal, then it is warm.
So normal uptake, it is mean even 16 to 35 to 36% is a normal uptake. When there is anything more than that, you are going to call it as a vivid uptake. It is not the 100% uptake. It is a vivid uptake is anything more than that percentage. Again, one more question, ma. Suppose you get a thyroid nodule here. In a secondary is there. Suppose the thyroid is going as a secondary in a bone, where you are doing uptake scan. What will be the nodule there? What will be it's a hot nodule or a cold nodule?
It is hot nodule, sir.
No, in a thyroid gland, if it is a malignant, it will
Cold,
produce
cold
cold
nodule.
nodule or warm nodule?
Cold nodule, sir.
Cold nodule. Suppose it is going to the secondaries with the bone or there, you are taking that.
So
Whether it
bone
will be a cold
metastasis will
nodule
be
or
hot
hot
or
nodule.
cold, sir, is asking.
It is a hot nodule, sir.
Why?
Due to increase iodine uptake in the secondary skin.
No. So hot and cold is only you can comparing with the other side. So normal, you are getting a gland is taking up. Malignant nodule will take less than that. That is why you are going to call it as a comparing is a low cold nodule.
Yes, sir.
In a bone will never take. So whatever the little the secondaries are taking, always you are going to get a hot nodule. So all the secondaries will be hot nodule.
Yes,
But all the primaries will be cold nodule. Primaries which are going to be then the thyroid is going to be.
Yes.
Ritesh bhai? Okay. What more, sir?
Radioactive
So,
iodine uptake study, which do you do?
vivid uptake.
Which do you do? Radioactive iodine
Nothing from
uptake
my
study.
side.
Which do you do? Which is better?
I will do radioactive iodine with the iodine 123 or technetium 99.
Which is better? Which is better, please?
Iodine 123 is
No.
as
No,
the
IV technetium
Technician
99
is
is
always better for
IV.
uptake.
We'll get the results fast. Okay.
Yes, sir. Within
Yeah,
20.
that is what you do.
What is the
But
difference?
now radioactive iodine uptake study is limited for certain things only. Not now we have the ultrasound, we have all the investigation. Radioactive iodine uptake study for diagnosis has come down. One is autonomic toxic nodule. Okay. Recurrent one. These are certain things. Okay. Retrosternal goiter, malignancy. Otherwise, you don't do a radioactive iodine uptake study.
Transient
I think so,
hypertension.
because I think you'll be doing the same day. With all the investigation and other things, you will come to a primary thyrotoxicosis of Graves' disease with all this thing. Okay.
Yes.
Technetium, what is the disadvantage of using technetium? It is very cheap, very easy to do.
Sir, technetium 99 give a discounted nodule.
It's a discordant scan you are talking about, no?
Yes,
The
sir.
discordant scan.
Iodine you are getting a hot nodule, or in a technetium you are getting a hot nodule, and iodine you are getting a cold nodule. So that is one thing. That is for use of that discordant scan. The disadvantage of using technetium scan is all the glands. It is not only the thyroid gland. Your salivary gland will also take it up. So you need to the focus will be less. So, but still nowadays the more of technetium is gland is used. What is concordant scan?
It is concordant scan.
But a concordance means that when the anatomical imaging correlates with the functional imaging, the anatomical imaging you can do with the sonography or CT scan, and the functional imaging you can do with the nuclear scan. So when they both correlate, it is known as a concordant.
Yes.
So that is why discordant and concordant scan using. Okay. So can you tell the difference between hyperthyroidism and thyrotoxicosis?
Hyperthyroidism, it is due to increase synthesis from the thyroid gland itself. And thyrotoxicosis it is a state of hypermetabolic metabolism due to increased circulating thyroid hormones, sir.
So that's
So how
it
do you
can come from
differentiate? Sir
any
is
other
asking.
source.
Clinically, right from the history part, how do you differentiate between hyperthyroidism and thyrotoxicosis? What all things you see in hyperthyroidism and what all things you see in thyrotoxicosis?
Clinically, sir. Clinically, sir, in case of hyperthyroidism, there is a increase enlargement of gland is present, which is not maybe absent in thyrotoxicosis.
Simple answer, ma. Hyperthyroidism just
Start with
increase in the
age.
level of
What
the
is the age of
hormone.
the patient of hyperthyroidism? What is the age group where you see toxicosis? Which is the age group for toxicosis and which is the age group for hyperthyroidism?
Hyperthyroidism is in early age.
Simple thing is hyperthyroidism increase in the level of the hormones alone. Whereas thyrotoxicosis, biochemical clinical manifestation with increase or without increase in the hormones. Okay.
Yes, sir.
Do you get thyrotoxicosis without hyperthyroidism?
Yes, sir.
Where? Tell me some conditions.
In case of the factitious.
Yeah, factitious.
Factitious,
How
Yes.
you differentiate them? What do you mean factitious?
Intensely taking a thyroid medication for the reduce the obesity.
So the patient is coming to you, you are having a doubt. How will you differentiate whether it is a factitious thyrotoxicosis or a real thyrotoxicosis? The only test exogenous hyperthyroidism, thyroglobulin level will be low. Whenever L-tox in the hyperthyroid T3T4 is raised, you will also get a thyroglobulin level will increase. But so here in this, so now to rule out a transient hyperthyroidism, you are going to do uptake scan and also the peroxidase antibody that will be able to different peroxidase and thyroglobulin. When you are coming to the factitious exogenous hyperthyroidism, then we must able to do the thyroglobulin test. Thyroglobulin test will be low in a factitious exogenous and in the indigenous, like a struma ovary or something else is indigenously coming out. So that will be always still it will be raised in there. So this is the two tests available to differentiate this. Like Hamburg thyrotoxicosis, that is also factitious. You are going to get it's exogenously you are going to get. What is the difference between Wolff-Chaikoff effect and Jad-Basedow effect?
Wolff-Chaikoff effect is when large dose of iodine has been given, thyroid constipation is developed, and patient decrease organification of the thyroid hormone, which result in the decreased circulatory thyroid hormone.
That is what effect?
Wolff-Chaikoff effect.
Wolff-Chaikoff effect is different. This is what you are saying is that thyroid constipation is Jad-Basedow effect. Wolff-Chaikoff says similar thing, exogenous thyroid you are giving, but it is happening in a diseased thyroid, not in a normal thyroid. Wolff-Chaikoff will never happen in a normal thyroid. Jad-Basedow can happen both normal and diseased thyroid. Normal thyroid, you are taking exogenous thyroid, the level of thyroid is coming down. But here you are giving exogenous thyroid, the level of thyroid is coming down because of the constipation effect.
Okay. Can you name any condition where there is a practical implication of these effects? What sir has asked. Any practical implication which will help you in managing this patient?
In patient with sir primary thyrotoxicosis, Lugol's iodine can be given prior to surgery before 10 days to reduce the circulatory to make the patient euthyroid, sir.
Good. So that is only will happen in a diseased thyroid. Yes, it will not happen in a normal thyroid. When the Wolff-Chaikoff effect will not happen in a normal thyroid.
So what is the difference between Lugol's iodine and our routine iodine, potassium iodide available in the market?
Lugol's iodine contain the 5% of iodine and 10% of potassium iodide.
Very good. So when you are planning for surgery, when you will give the Lugol's iodine?
Sir, I will give the Lugol's iodine 10 days prior to surgery.
So suppose you are giving for 2 weeks, what will happen?
For 2 weeks, thyroid FK develop, and then patient develop the increased thyroid circulatory thyroid.
Phenomena will happen, and
Yes.
also it produces a lot of fibrosis. So you will not give for a long days.
So how will you treat this
when you
patient?
plan
Sorry.
for surgery, hereby when you plan for surgery, you have to look for the sleeping pulse rate, a clinical bedside indicator to look for the normal euthyroid. Okay.
Yes, sir.
So when it's normal and your T3, T4 are normal, you start with Lugol's. I think how many of you are using it, I do not know. So Jalal sir, Apurva sir, are you using it, sir?
Previously, it was available at one of the
all the
centers.
glands
Now
are
we are not getting it, sir.
It is not available. What is Lugol's due to the gland, ma?
I'm not using it because it is not available. Plus,
Yes,
I am
sir,
able
yes.
to maintain my patients on antithyroid drugs plus lithium if it is, and steroids if it is needed. So I
You
don't
are
require
using-
leukocytin nowadays.
You are using steroids, sir?
Yeah, steroids because it may stabilize the cardiac membrane before surgery. So it is very helpful for 2
What
or 3 days
steroid do you
before
use, sir?
surgery.
What is the dose?
Dexamethasone 4 mg IV 8 hourly.
What steroid do you use?
Dexamethasone 4 mg IV 8 hourly.
When do you give, sir, please?
Sir, 2 to 3 days before surgery.
Yeah, see. So when Lugol, somebody will ask you, ma, what does Lugol's do with the gland?
It is decrease the vascularity of the gland and make the gland form.
How?
By producing the fibros.
No, it intakes the iodine contents go inside. It increases the size of the gland. Thereby, it compresses on the vessels. So makes the gland firm, so less vascular, and also prevents release of the hormones. That's called thyroid constipation.
Yes, sir.
Okay. If somebody asks you, as Professor Ritesh said, he's not using it, but we have been taught like that. We use Lugol's iodine. Okay.
Yes.
So you should know the composition. How many drops you give for how many days?
5 drop for 10 days.
5 to 7 drops in
For 10 days. In 3
a
times
glass of water.
3 times
In
a
a
day.
glass of water for 7 days. 7 to 10 days. Okay.
So how do you give?
I will
You
give
are asking.
5 to 10 drops 3 times a day with.
No, beta. How do you give? The way of giving. He just sips in 10 drops or something else?
With, sir, fluid, milk-based fluids. With glass of water.
It is said we routinely should be giving it through a dropper or through a straw. Basically, because I mean, even I have not used it for last 10 years now, but it stains the teeth very badly.
Never ever give a Lugol's iodine directly on the tongue. It will burn it. Never give iodine directly on the tongue. Just dilute it with the water or with milk and then give only. Otherwise, it will burn very badly the tongue.
Right,
you
sir.
you give it, you take up for surgery. What are the drugs will you stop prior to the day of surgery? And what are the drugs which will continue after the day of surgery?
Sir, prior to surgery, 1 day before the surgery, antithyroid drug I will stop.
No, be specific in which drug.
Like
Carbimazole is stopped prior to surgery.
stop.
Stop carbimazole surgery, and post-operatively you have to continue with the propranolol because of the handling of the tumors. Sir, if there's any difference, you can contradict.
Yeah, I have a difference in opinion, sir, because we give the antithyroid drugs plus beta blockers till the morning of surgery and steroids also. So we do not stop carbimazole. We keep giving it either carbimazole or methimazole till the morning of surgery also, stopping immediately after surgery. Beta blockers and tapering doses after surgery.
Yeah, that's what beta blockers you have to give for another
The reason is
4 to 5 days.
the half-life of thyroxine.
Handling of
it is because of the half-life of thyroxine is more than 7 days. So whatever the preformed thyroxine is still active. So we want to have the control over that. That is the reason why you are going to control the beta blocker to be continued for next minimum 1 week after surgery.
1 week.
Carbimazole is effective only as long as the gland is there. So once the
Gland
gland is removed, the carbimazole role is not there.
Centrally acting.
Sir, we are
What
talking
surgery?
about surgery because senior people are with me and Uriben is also there. I would like to know the role of radioiodine ablation.
Yeah, that's why I was coming on that what is the
Right, madam.
indication of
I knew.
what is
Madam,
the
please-
indication,
Please
Yeah,
come
please.
out with your expert views, madam.
Florina? What is the indication of surgery in this patient?
Yeah, that's what I want to ask.
Sir, patient have a exophthalmos with some
Will exophthalmos will resolve after surgery?
no, ma'am.
So then that is not an indication.
Due to a large goiter, I will prefer the surgery.
The proper answer will be the patient is having symptoms since last 2 years and it is not controlled by the antithyroid drug. So it is an indication for surgery. Why you will not go for radioactive iodine in this case?
Due to patient have a exophthalmos and large size of the swellings.
What is the age of the patient?
36-year-old.
So is that an indication of not using radioiodine?
Yes, sir. Radioiodine scan is not used if the patient want the pregnancy in last 1 year.
That is not about having pregnancy, but in reproductive age, you should not use radioactive iodine.
Yes, sir.
For ablation purpose.
Yes, sir.
If left alone, will this turn into malignant?
This is one thing is like reproductive age group, it is better not to use because even though we say that it's after 1 year we are using, but still there are evidences say that it can induce ovarian cancer and other problems are there. So it is better ablation
turn into malignant.
be avoided in the younger age group people. Second,
Madam,
in the patients with
if
exophthalmosis, already exophthalmos, there is an exaggeration.
So let me tell you.
This is not in a patients with sometimes it can exaggerate, but the percentage is less comparatively. Patient, it is nearly 40% of the patient can have a exaggeration. That is why we are. The third is a smoker who patient has a history of smoking is there. That is also another contraindication for using a radiation therapy.
Whether this patient is male, then will you go for radioactive iodine or not? Florina?
If it is a male, then only I do not do a radioactive iodine because the patient have a exophthalmos which is aggravated. Or if the male patient is smoker, then I will do not do a radioactive iodine. Otherwise, I will do.
Okay.
Ritesh bhai, any expert comments on your side?
No, sir, not at this point.
Okay. Jayesh bhai? Okay.
Fine. That's fine. Radioactive ablation means what? What do you mean by that? Radioactive ablation?
I have a question, sir. Please. If by radioactive ablation, can you manage a primary thyrotoxicosis? And what ablation, what dose, sir, please?
I can manage the patient.
No, I'm asking it to the faculty, please.
Madam, you should be the right person to answer that question.
Yeah, the dose is first there is a radioactive iodine uptake scan is done, and by that the dose is decided, and for it is individualized. And after the first dose, if there is no response, then the second dose also is given.
I did 131 ablation, madam.
Sorry?
I did 131 ablation, madam.
Ablation always 131.
Yeah, in India only 131 is available. That's why ablation is done by
131. It's not available in India.
No, we are not doing it in my place. That's what I wanted to know. By giving that, have you treated a case of
it's more expensive than surgery. That is one reason in a government hospitals. It is because each gram of tissue you are going, the millicurie dose is going to be increased. So the more the dose you are going to accumulate, so the larger size, the more dose, it is more dangerous. So it is Preferably, surgery is economically also beneficial for government hospitals for us.
What is their experience, sir? Have you given radioactive ablation and have you totally destroyed the gland, sir?
Yeah,
Anybody?
we have a good experience, sir, with radioactive iodine ablation.
How
I
long,
agree with
how
you,
long,
ma'am,
how long
that-
will it take, madam, for this gland? This
6
patient.
months
This
to 1
patient.
year.
This patient.
6 months to 1 year.
How many sittings, madam?
Maybe one. May
And,
require second dose as per gland size.
and what about other medications that is required? You said 6 months to 1 year. So till
Yeah,
then,
we have to give antithyroid drug during that period, and we have to monitor whether when the patient is going to convert it into the hypothyroidism. So till then, we have to continue with antithyroid drug.
Okay.
This has been your experience. Anything?
Yes, sir, I agree with Urvi, ma'am. Nowadays, radioactive iodine is very effective. We don't treat this patient with surgery nowadays more. Give iodine. Iodine is very, very economical. In Mumbai, only in private sector, it is costing 6,000 to 7,000 one sitting. We give 1 or 2 sittings only, 6 months apart. And usually within 1 or 2 sittings, the patients become hypothyroidism. That is better. It can be easily controlled by thyroxine medications.
And do we need to do anything
does the
about
gland
the thyroid
decrease in
gland
size,
per se?
sir?
The anatomy?
Yeah, usually the gland decreases in size.
Okay, so you don't need any follow-up therapy then?
Then
Follow-up is
We are
being
getting in Tamil Nadu and Toronto, it is almost 30,000.
Pardon?
The gland decreases in size.
Yeah.
But does it totally disappear? But you have to, there will be some amount of gland or not?
Some amount of gland may be there, but it is usually firm small. So then nothing is needed after a few years of iodine medications. It is very safe medications nowadays. The only thing is that patient is planning for pregnancy, then we have to avoid. Otherwise, we can give safely even at this age. That is not an issue. And the dose is usually 10 to 15 millicuries in single sitting. Any dose which is more than 30 needs admission. Any dose which is less than 30 does not need admission.
So if you give, sir, there is no response, what do you do, sir?
We keep on continuing with the antithyroid medications. We repeat the dose after 6 months for iodine. And then after 2 sittings, if it is refractory, then we may plan for surgery. But usually the iodine medication in 2 sittings kills the hyperactive gland and the patient convert into hypothyroidism. It's very usual case.
Have you done surgery on any, after giving these drugs?
Yeah, I have done surgery, but very few. More than de novo patients when the glands are very large. When the glands are very large, only then we prefer to operate, otherwise not.
Okay, thank you for clearing me.
Jalal sir, you are saying something? I didn't get it.
No, I was so happy to hear that it cost only 6,000 there, but in Tamil Nadu and Toronto, they are charging nearly 25,000 per sitting.
Sir, Jalal sir, whatever you are talking about
15
iodine,
millicurie, and if it is comes to 30,
Jalal sir, may I say something?
That is why we prefer now, because of economic reasons, surgery is much cheaper.
Yes, Jalal, you are saying something.
Yeah, sir, the iodine which you are talking about is for this thing, thyroid cancer, post-thyroid cancer surgery ablation, and that is costing 70 to 80,000. I agree, but only for this dose, the low dose iodine therapy, it is very, very less. It is hardly 6 to 7,000 across the India.
What is the dose difference, please, sir?
The dose for iodine ablation in hyperthyroidism is 10 to 15, and the dose for thyroid cancers after surgery is usually 50 to 100.
So we have to get everything from abroad, north only, sir.
No, sir.
So by the time it comes here, it becomes costly. That's why we go for surgery.
Sir, in India, it is produced at Bhabha Atomic Research Center.
Yeah, it is produced, yeah.
And it is supplied across India same day. And if it is less in quantity, then the centers call from Israel or Turkey. And even then the cost is not much high. It can be managed easily, but still for hyperthyroidism, it is very, very economical. Hardly 6 to 7,000 rupees or max to max 10,000 in any center.
We will try, sir. Thank you.
Good, sir. Good.
Thank you, Dr. Ritesh.
Again, sir, more learning for us.
Send patient to us, sir. We will treat with the radioactive ablation.
I'll get your numbers and both numbers and send.
Madam, I cannot send. I need those students to understand and learn.
Yes. No, sir. Florin, this is a discussion between us.
My last question to Florina.
Florin, this is a discussion
Florina, if you are
between
operating, then what kind of surgery you will prefer, subtotal thyroidectomy or total thyroidectomy? And why?
I will prefer total thyroidectomy in this patient because in case of subtotal thyroidectomy, I will prefer a total thyroidectomy or the near total thyroidectomy. In case of subtotal total thyroidectomy, there is a remaining tissue which act as a antigen for thyroid receptor antibodies.
So the recurrence rates are very high after subtotal, right?
Yes.
What will you take care of in case of near total or almost total thyroidectomy? Which structures?
During surgery, I will preserve near the Berry's ligament to prevent the injury to recurrent laryngeal nerve.
Any other structure?
Only thing, only
Parathyroid.
Yes.
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 Now, Ritesh sir, I'll ask you a question. Now they are telling only there are two types of thyroid. One is total or hemithyroid.
Yes, sir. Agree.
Because other thing is, when we were studying, myself, Jailal sir, reading, I'm not telling.
Yeah, we did a lot of subtotal.
We did a subtotal, partial thyroidectomy, all these things. But now they say total or hemi.
Sir, I would definitely say that after subtotal, there was a lot of, I know of a couple of patients where hematoma was a problem and we had to open up the wound in the ward. I hardly remember any such patient after total thyroidectomy.
This Dunhill's procedure also they say, but we are not doing it as per sir. What is your madam, Urvi madam or Ritesh sir?
May I answer, sir?
Yes, yes.
Yeah, ma'am, please go ahead.
No, I agree with sir.
Okay. See,
total or AME?
After doing
total
a total
or AME, madam?
In thyrotoxicosis, definitely near total or total.
Yes, Ritesh, what is your take?
See, after doing a total thyroidectomy, the difference between subtotal and total is that the people who are doing subtotal were doing it with the intention of saving some thyroid tissue, so patients are not depending on thyroxine medications. But what happens that over a period of time, we have seen that after doing a subtotal, still patients requiring thyroxine, maybe a lower dose, but they are requiring. Plus, the chances of recurrences are very high. So that is why doing a total thyroidectomy, now thyroxine is a very, very safe medication. You can give easily lifelong. So do a total thyroidectomy, put the patient on thyroxine medication, and the patient can be managed very easily.
One more point.
What is the incidence of hypothyroidism after total or near total?
Madam, after hypothyroidism, madam, that is not, they have to be hypothyroid, madam.
100%.
Yes, ma'am. That is a completion surgery. That is what
like radioactive iodine only. Yeah.
Yes, ma'am.
The only thing I would like to point out is that when we are doing subtotal thyroidectomy, the dictum was don't try to look at the recurrent laryngeal nerve. You may damage it or injure it. Nowadays, with total thyroidectomy in play, we always safeguard the nerve. We see the nerve and safeguard it, keep it safeguarded repeatedly during the surgery. My boss always used to say that please don't look at laryngeal recurrent. You may damage it.
Sir, how many cases of malignancy have you seen in toxic, sir? Because I have not seen anything.
Ritesh bhai, I have not seen anything.
Sir, I have seen many cases of malignancy in Graves' disease. So that is why we work up fully before surgery by doing a sonography, a very good sonography.
In toxic, sir?
Pardon?
Yeah, in toxic also.
Toxic,
yeah, I'm talking about toxic only.
It is less than 3% or 4%, they say.
It is rare, but it is there.
It is
but
there.
Sir has more experience.
How do you encounter, madam? How do you treat this patient? How do you diagnose the patient? What do you suspect?
We have to go for a
Florina, go to the gallery, make a gallery, stop the slide sharing. Ritesh bhai, please.
Yeah.
So you have done very well. We are discussing our things. You can also join in. No problem.
Sure.
Sir.
So in any case of in any nodule with the that is present in sonography in Graves' disease, so we have to be very careful that it can be malignant, because what happens in Graves' disease, if there's a malignancy,
what make you to suspect it is malignancy?
Sir, there are a few sonographic features which are pointed towards malignancy, like hypoechogenicity, like irregular margins, increased vascularity, peripheral or nodular, and microcalcifications.
That is there, sir. But in hyperthyroidism, toxic nodule, you keep a USG and find out these things, sir.
No, sir. I'm talking about not about toxic nodule. Here I'm talking about Graves' disease with nodule.
No,
Graves' disease is a different thing.
Okay.
Okay, Graves' disease is a diffuse goiter with a nodule inside anywhere in either on the right or the left or even in both sides, but they are non-functional nodules. So on the basis of sonography features, if they are suspicious, even in Graves' disease, I would like to go for FNAC in them.
Sir, will it not bleed, sir?
Not at all. Never,
No,
sir.
sir.
It will
But
not bleed.
can we go for
Yeah.
a technetium scan or radio imaging technique and go for a nodule?
PET scan will not help, ma'am, because PET scan even in normal thyroid malignancies or in Graves' malignancy, it may or may not show uptake. And many times in benign nodules also, it shows uptake. So PET scan is not very sensitive modality for thyroid cancers preoperatively.
Hyperthyroid, you are not supposed to do an FNAC.
It is not the case, sir.
That's the teaching,
No, it is
sir.
for
But
ultrasound guided. When the only on the nodule we can do, sir.
Yes,
you can do, sir.
we can do it.
It's high resolution ultrasound. Just strike at the nodule. Sir, will you get malignant cells, sir?
Sir, if a good USG guided FNAC is done, then we send the slide for FNAC reporting, cytopathology reporting, and as per the Bethesda grading, we plan accordingly.
Okay.
So regarding the planning part, sir, can the CECT help with availability? I mean, if it shows lymphadenopathy and all.
Sir, CECT, like I told, or Florina has told that lugol's iodine should be given 10 days before surgery. So likewise, CECT, it also, the contrast contains iodine. So it should also be done within 10 days of surgery.
Right.
Not before. And definitely, if I'm planning for surgery, I will go for CT just before surgery.
Okay, sir. But total thyroidectomy in thyrotoxic malignancy in a toxicosis, and post-operatively the report comes as malignant. Is that suffice, sir?
Sir, pardon, can you, because your voice was cracking in between, can you repeat the question?
No, sir. You have done a total thyroidectomy.
Yeah.
But the report comes as malignant papillary carcinoma.
That is fairly okay. No issues.
No issues.
After surgery, send the patient for radioactive iodine ablation. That will be done after 1 month of surgery.
Oh, that is enough, sir, isn't it?
Okay, good.
Yeah, that is
you
enough.
have come across malignancy in a toxic primary thyrotoxicosis.
But lymph node dissection will not require, sir?
Ma'am, that is why before surgery, I ascertain what kind of surgery I'm going to do. If I had a slight hint of CA, then during surgery only, I do a central compartment prophylactic lymph node dissection then and there only.
Yeah, then frozen section also will help.
Frozen section, if I'm having a indeterminate diagnosis and I'm planning for HEMI, then frozen. But if I'm doing a total thyroidectomy, then usually I don't go for frozen section because I'm anyhow removing the whole thyroid.
Right, okay. Sir. Right, sir. A good discussion.
Nice.
Jailal, sir?
Nice point, sir.
Yeah, it is fine, sir.
Okay. Any more questions needed to be asked?
Talking about thyroidectomy, we are not going into the discussion of the normal procedure, but on the round, what is the most other complication you are going to expect after doing a total thyroidectomy? The first day of your rounds on the ward.
Transient hypoparathyroidism. Sorry, it's for Florina.
This is for the student.
Sorry. This is for the student.
This is for student, Ritesh, sir.
I mean, on the first day of rounds, what are the things you look for? What are the complications you are going to look for?
Hemorrhage, or patient have any.
First day of the rounds, done that you are going to the ward. You are not going to expect a hemorrhage on the first day. The rounds.
In the evening, your intern calls you and said the patient has got dyspnea.
Patient also, I will look for the dyspnea.
No, patient, evening you do and go for your lunch around 4 o'clock or 5 o'clock. The intern calls you and says the patient has got swelling in the neck with dyspnea.
So after surgery, after 4 hours, if the patient has dyspnea, your junior calls you up, okay, the patient has dyspnea, what will you do? Sir is asking, what do you expect and what do you do?
I will first expect the due to hematoma formation. I will do, first I will open all the stitches up to the strap muscle in the ward, and then taken patient to operating theater, intubate the patient and control the bleeding.
Yes. No answer Jalal's question, sir. Sir's question. What are the other complications?
I'm asking the second day on the first post-operative day. You are going for rounds.
On the second day.
Yeah.
Patient.
In your rounds, what will you look for?
Patient have any periorbital numbness?
Okay. For what you are suspecting?
Hypocalcemia. Transient hypocalcemia.
What are the types of hypocalcemia you get?
Transient hypocalcemia and permanent hypocalcemia. Transient is
When will you say transient? When will you say permanent?
transient is seen within
When do you say transient hypocalcemia? How long it will be there?
transient hypocalcemia is up to 3 months.
6 months.
You usually get it on the second
So persisting
post-operative
for more
day,
than 6
second
months,
late night, or third early morning. You
Spurious
get a
hypocalcemia.
hypocalcemia. What is the normal level? What is, when do you say it's transient? What are the tests you know to do?
I will do the Chowstek sign, and I will do
What is it? Carpopedal spasm.
pedal spasm. Yes. When the blood pressure curve is inflated up to beyond the systolic pressure, patient develop the carpopedal spasm.
So you are doing the test and the value shows as only a 6 milligram, the calcium level.
Yes, sir.
So you think it is hypocalcemia? So what are the conditions, fallacies you get in the calcium? What is factitious hypocalcemia? What is spurious hypocalcemia? So can a patient with a liver disease have a defective calcium level?
Yes, sir.
So what do you do?
I will give the injectable calcium gluconate, 10%, 10 milligram.
No, I'm not asking the ma'am. You are still in the confusion. You are not giving your blood level is coming as a low. But are you immediately go for a treatment, or you will think for any other cause for hypocalcemia is there?
I will think for any other cause.
So what comes to your mind?
So you must read. At least you go and read. There's a lot of calcemia, spurious hypocalcemia, factitious hypocalcemia, especially in the liver disease. And also you must know the hungry bone hypocalcemia. You must also read hypophosphatemia, whether the phosphate level is also there. Then only you are going to treat. And as long as you are going to read the total calcium level, you should not start the treatment. You should.
That's why before you treat, you have to look for the calcium level, the phosphate level, all these levels, then only start doing. When you're doing total thyroidectomy, you have to look for this. Okay.
Yes.
This is primary, secondary, tertiary hyperparathyroidism. Okay.
So normally, when you are having a 4 parathyroid is there, if you remove one parathyroid, will you get a calcium level will be low or high? Will be normal.
Normal. Sir. When all the 4 glands were removed,
get even if you remove one gland, there will be always a defect in the calcium. That's why you are not going to take it as a permanent. So it's all in a transient level. So that is why they are going to keep it for a long time to convert it into the permanent.
How do you?
So when you are treating, what other drug also will give? Only you will replace with the calcium, or you will replace with anything else?
Vitamin D. Vitamin D. Sir.
What is that? Cholecalciferol.
Or what?
Now, why do you give this calcium?
How do you want to give
calcium?
Vitamin D. Increase the uptake of the calcium from the GI tract and also from the bone, and also increase the avoid the loss of the calcium through a kidney.
So you give calcium. How do you give the calcium? Tell me.
I will give a calcium IV formula, calcium gluconate, 10%, 10 milligram.
Oh, very fast?
How do you give it? How do you give it is the question. Bata.
You give very fast?
No, I will give it over 10 minutes.
Slowly.
Diluted or not?
Why? A lot of litigation is going on, Florin.
Why? Sir,
So that's
why
what I asked.
slowly?
How do you give slowly? The patient comes to you post-operatively. You give a drug, the patient sudden collapses, you are answerable.
Asystole.
So that's why you should know how to give.
Calcium affect
What
the
is asystole?
cell membrane.
So you give very slowly. It will go in for cardiac dysarrhythmias or it will go in for cardiac arrest.
And asystole is a picture. It can go for
Asystole,
even
very
that.
good. Thank you, sir. Thank you, sir.
So how do you, these are the questions we normally ask in the ward rounds. This is not the question we are related to the patient. When we are going for a ward rounds, so the more questions will be on this. So suppose with the calcium gluconate, you said how much you will give?
10 milligram, 10%.
Is it a milligram? So are you calculating the deficit in a milligram or milliequivalent?
I will count in a milliequivalent.
So how will you
kindly read, ma. Kindly read, ma, because more than a surgery, the post-operative care is more important.
Divided by Malek.
Because my professor
So
used to say,
these points we should be reading in ward round. So the most questions will be on this only ward rounds. Otherwise, good.
Good. My professor used to say,
Suppose the patient.
My professor used to say,
is
after doing an abdominal surgery, only if the patient passes flat test, I am satisfied. So on an abdominal surgery. So take care of the patient. That's what Sir was asking. So you take care of the patient.
Going for rounds and you are seeing the temperature is 104. Patient is very little toxic. And what do you suspect?
Patient thyroid storm.
So how will you manage?
I will manage the patient with the hydration, with the IV fluid. Then I will give the blankets to the patient, and then hydrocortisone IV 500 milligram state, and then I will give the hydrocortisone 50 milligram. No, sorry, 5 milligram per kg or the dexamethasone, and I will give the anti-thyroid drugs. Propyl uracil 100 milligram 3 times a day, and I will give a propranolol.
So you are going to give oral propyl uracil or IV?
Propranolol or something else, beta?
Sir, I will prefer propranolol because it prevent the peripheral conversion of T4 to T3, and also for the symptomatic relief of the.
Beta, in emergency in emergency conditions, will you get propranolol IV?
Yes,
which IV beta blocker you will prefer?
Ismolol.
So why you are telling propranolol in emergency conditions?
So emergency.
I will prefer the Ismolol.
So Ismolol and then switch over to propranolol when the patient is stable. Then you can switch over to propranolol oral, and you can combine both also. Ismolol start IV and at the same time give oral propranolol if the patient is able to take.
Yes, sir.
Sir, somebody has asked in the chat that do you give steroids in emergency? It is required, Ritesh bhai?
Yes, sir. It is important.
Thank you, sir.
Steroids are very important.
It is important drug.
Yes.
Right,
Suppose the patient.
Yes,
sir. You are seeing on the rounds, you are seeing a patient is having a stridor. What you will do?
Stridor. Stridor is also developed due to a hematoma, which is compressed over the trachea.
It's very rare. You are on the second day.
But sir is asking on second day on the rounds.
I will give the steroid. It may be due to laryngeal.
It is not subsiding.
I will put the endotracheal tube.
The ideal thing is you get an emergency ENT opinion, anesthetic opinion. You go to the If they say plan for tracheostomy, do a tracheostomy.
Yes, sir.
Am I correct, sir? Jailal, sir?
Yeah, it is better you put on a.
You get the
So
opinion
is it?
now. In an
So you
institution
must
like
also
this,
know
you have a
in the
multidisciplinary
postoperative
approach. Okay.
recurrent angina injuries, single recurrent injury, bilateral recurrent injury, and what are the newer advancements it has come. Suppose the patient has a permanent recurrent injury, and what are the other surgeries procedure, how you are going to lateralize the cord. This also you must read on that. There are a lot of now
How do you know
invasive.
postoperatively the recurrent laryngeal nerve is injured? Don't say hoarseness of voice. The anesthetist removes the tube.
Tube and see the movement for the vocal cords, sir.
Vocal cords are not moving. What will be the position?
Sir, position paramedian or median, sir.
If suppose you have injured the superior laryngeal nerve, external branch of the superior laryngeal nerve, what will happen?
Patient patient decreases the tone of the voice, and patient can't use the high pitch voice.
That later, but on extubation, how will they say? The vocal cords will be shortened and edematous. Okay.
Yes.
That's what. Okay. Right.
Nowadays, probably we don't see such patients, but basically,
Graves
disease. In Graves disease, we need to look at the terminology of tracheomalacia. What is tracheomalacia?
Tracheomalacia is a condition due to increased vascularity in the Graves disease over the long period. There is a washout of the calcium from the tracheal cartilages, which make it like a scabotrachea. Postoperatively, after removing the large goiter, patient.
There's a weakening of the tracheal rings. Weakening of the tracheal rings. Posterior. Yeah. Weakening of the tracheal rings.
Yeah, Florina, what
is always anterior-posterior.
Posterior. Anterior-posterior collapse. The posterior rings are weakened because of the long-standing goiter. So you have the weakening and collapse. That should be tracheomalacia.
It is a...
Ritesh, you are saying something?
Yeah. Florina, what is scabotrachea? What is the definition of scabotrachea? What are the components of scabotrachea?
Scabotrachea, it is from upper to lower, it is decreasing in diameter.
So that is known as tapering. One is tapering, one component is tapering. What are the other two components?
Anterior posterior diameter it's decrease.
So see, that is tapering. Second component is deviation from one side to the other. Okay, one component is tapering, second component is deviation, and third component is angulation. So it is not deviated only from one side to the other side, it is also angulated.
Yes.
So that is why it is causing severe breathing difficulty.
Do not have all these components. Tracheomalacia only say demineralization. The cartilage is demineralized. Mostly it is anterior-posterior. Scabbard, mediolateral compression, like a scabbard. It is, we know the shape of the scabbard, and you will be able to say the narrowing.
On X-ray, you can see scabbard trachea. You cannot see tracheomalacia on X-ray, if I am not wrong.
On X-ray.
Tracheomalacia, you should be careful when you extubate the patient. There will be collapse of the tube, and you need to reinsert the tube if at all required. Am I right, sir? Ritesh bhai?
Yeah. Yes, sir.
Because most of the time these two terms are taken together, but it is relatively a different etiology. And why you are bothered about collapse of trachea? Our esophagus is it open always? Esophagus is relatively closed. Only when you are eating, it is opening up. Why do you want the trachea to be always kept open?
For this respiration.
You are only breathing 16 times per day. So is it enough? It opens only when you are taking a breath?
No, even in the expiration, trachea is open.
No, both. That is 16 times only it is happening, no?
2.
Why do you want the trachea to be always kept open? So that is because you have dead space volume, you know. It is always taking place in the exchange. Dead space volume It's a volume which is not taking place. Though we are breathing 20 times maximum, 72 times the exchange is taking place. So every time the fresh air is needed. So this, what is there in the dead space volume will be taking place for the exchange which is taking place routinely. So it is a continuously, it is changing this volume. So dead space volume is mandatory for your vital capacity. That is why we want always this any collapse which is happening immediately will have a problem. It is important you are going to check for tracheomalacia. You are going to, if there is a scabbard trachea by doing X-ray. That is going to help you, because once it's collapsed, it is a very difficult. Not like other tubes, esophagus or other things. When the foot is going, it will open up. The rest of the time, it will be collapsed. But here it is always, it is kept collapse because of the dead space volume is mandatory for taking part in the respiratory cycles.
I'm discussing one thing, tracheomalacia. For everyone, during surgery, how to prevent it? After during surgery, what shall we do to prevent the tracheomalacia after surgery? If we have identified the tracheal wall is collapsing during surgery, what shall we do?
Do tracheostomy.
No, beta. Tracheostomy is a later thing. Apart from that, because tracheomalacia usually happens on one side only, not on the both sides usually. So if there's a one-side tracheomalacia, what shall you do during surgery, apart from tracheostomy, so that tracheostomy can be prevented? See, you take some sutures, take some vital sutures and fix them to muscle so that the wall is in the tension and not collapsing. So even after extubation, the wall will not collapse, and keep the patient intubated for 3 days. And after 3 days, with a flexible bronchoscopy, just take the do the extubation. Until then, the wall is settled and the trachea will not collapse usually. If then it is collapsing, then you can go for tracheostomy.
Sir, one question to you, sir. Is it possible, suppose we are identifying a particular ring is collapsed, can we excise it and suture it rest of the
No,
time?
sir, not required. See, if one ring is collapsing, that doesn't need anything. But it should be on both sides. Tracheomalacia, if it is unilateral, then usually nothing is required except simple suturing, which is hinging from trachea to sternomastoid or some other area in the neck only, so the trachea wall does not collapse, and just keep the patient intubated.
Yes.
Are there any pre-operative indication that you keep the tube inside?
No, sir. No, it cannot be identified pre-operatively. We can just guess whether we will be able to encounter this difficulty during surgery or not, but no pre-operative indications.
Now, can we feel the trachea and say that you keep it intubated?
Yeah. So what happens is, what I do during surgery, after removal of thyroid, I tell my anesthetist to withdraw the tube gradually till the level of vocal cord.
I think so.
And then I feel the trachea, whether it is collapsing or not. If it is collapsing and it is softened, then I will use the sutures. If it is not softened, if it is still hard, I will not do anything.
What sutures you use here, sir?
Vicryl, 2-0.
Now, what do you do with it?
Sir, I take the tracheal wall cartilage and suture it to sternocleidomastoid muscle so that the tension is there.
Is that a permanent solution?
It happens. It helps usually.
So fibrosis sets in right later on, sir.
Yeah, after some time, the tracheal wall also gathers strength, so it doesn't collapse. And within 3 days of intubation, we get the good results, sir.
Okay, sir. No, I have not heard about it. I have not done it.
After 3 days, if it is collapsing still,
sir,
then you may plan for tracheostomy.
Yes, sir. That's the final solution.
Jalan sir, have you heard of நீங்க பண்ணிருக்கீங்களா? நான் பண்ணல.
Hello.
Jalan sir.
Yeah, Jalan sir. Sorry, my internet is a little sketchy.
Okay, these are all our questions, madam. Don't worry about it. Florina?
Ritesh bhai, anything left out?
I think it's too much for a student, sir, because it is 2 hours and 45 minutes for a student at this level. So we should not torture her more.
Sir, please don't take it that way.
Just joking, sir.
I mean, the thing is that we try, and they know that every year we do this, and we try to prepare them for the examiners as well as the patients in the future, sir.
No, that is a very good
With the help of experts like you and Jailal, sir, we are really trying to do that in a good way.
No,
Thank you so
Ritesh
much,
has
sir.
said 2
Okay.
hours and 45 minutes is not for the exam. Exam is almost 25 to 30 minutes only.
You never know, sir, what happens in that 25 minutes.
No, we have to at last say a few good words.
No, she has done. Oh, sorry, I cannot say she is my student. It's up to you to say
No, she
what.
is our student, sir. She is our student. Florin, you have done extremely well. And you have done all the points well. Of course, in every presentation, in every exam, there will be some comments. Don't bother about it. And take all the points into your mind. And if only asked in the exam, you answer. Okay. Otherwise, don't tell what myself and Ritesh have discussed about malignancy or tracheostomy, suture, don't do. You keep going in the normal pattern, and whatever they ask, you ask. Previously, there was one question. When you asked, you answer to that question, you will definitely pass. And keep all these points kindly after the class. Write it in your paper and keep it with you. Okay.
Yes, sir.
And all these questions, see, you will be taught everything, but not asked everything in the exam. So keep everything in your mind. And Professor Ritesh, Professor Madam, Urvi Madam, all these things they've asked. Okay. All these questions, you keep it in your mind. If they ask, you tell me. And don't quote in the exam that in the class it was told like this. Okay. What you read, you tell. Your presentation was good. Only thing was your complaint, but otherwise everything was good. Your answer was good. So keep it up. God bless you. Good luck.
Thank you, sir.
Jailal, sir.
I think
Yeah, I am back. That was small.
Yeah, he's back with another. So, anything left out, sir?
No, I think it's fine, and we had enough time for a discussion. And our candidate is absolutely fantastic, and your theoretical knowledge is very good. My only request to you is don't put your theoretical knowledge into the clinical case. And your clinical scenario, which you are telling, what is exactly there? The patient is there, if you are presenting, then it is up to the second part is your cognitive part, which we are always asking. But what the first thing which you are going to expect is how much importance you are giving for the clinical examination, clinical history taking, and how you are able to correlate things. All other things is only an additional marks to you. It is going to give you. But the basic is what you are going to the examination. We have not, only thing we have not discussed about and how you are going to examine various methods of examination, which I am sure because you have a very fortunate teachers. We are very, very illustrious teachers, and you will all learn very well. So, I mean, we are you've been one of excellent student in the class.
Ritesh bhai, any anecdotal things you need to put up?
Sir, it was a very good class. Thank you so much for inviting me. And Florina has done extremely well. I agree with the sentiments of Dr. Jailal. And I appreciate your students also. The previous class was also very good. This class is also very good. Thanks to all the teachers who have taught the students so well, especially Pankaj sir, Srinivasan sir, you, and all others. It really shows the quality of the department, how well they are teaching the students. Thanks,
Sir,
sir.
even our guest speakers and guest teachers, we are also thankful to all of them. Urvi ma'am, anything on your side?
Yeah. Thank you, sir, for inviting
You have
me
any
also.
questions, ma? Abhijit, sorry, Dr. Florin, you have any questions to be asked to the expert opinion? Urvi madam is there. Ritesh is there. You have any
None,
questions?
No, good.
Good. Very good.
Okay, sir, then I'll take your leave.
Thank you, sir. Thank you for giving the opportunity.
Thanks,
Thanks,
sir.
sir. It is
Bye,
my
everyone.
pleasure. Thank you, Ritesh bhai. Thank you, Urvi ma'am. Thank you, Jailal sir. Thank you, Srinivasan sir.
Thank you, sir.
Thank you. Thank you, sir.
Well done, Florin. God bless you.
Thank you, sir.